Hello everyone. Good afternoon to everybody who is on YouTube and the ones who are going to interact also. Uh, I would like to say that this CME on liver pathology has been organized to honor and commemorate Dr. Ashim Das' nearly 4 decades of dedicated service and teaching to the students of Department of Pathology, Histopathology, and to the other departments of this institute. He has many qualities. He is a wonderful man. He is a great friend. He is honest, hardworking, diligent, dutiful, conscientious, and whatnot. But I have to say that he is a brilliant teacher and is very fondly appreciated and remembered by his residents from yesteryears as well as present times. He is a great diagnostic pathologist, and we all know it, who simply loves and enjoys his work. This is a small CME in a simple way of expressing our respect and regard to him from the Department of Histopathology. Due to uncertainties of COVID pandemic, it is very difficult to organize a big event in advance. So we wanted to do something special for him, and we made an effort, and we planned this short scientific event on a Saturday afternoon. We chose this day because he would be retiring on 31st August, and this afternoon we were free, and we thought that our colleagues and other people who are associated with him would also be free. So they will find it easy to attend and listen to the man just before his superannuation. By the way, we have also planned other farewell parties on 31st, and many people will have chance to express their gratitude there as well. At this point in time, I can say that he will continue to inspire and teach pathology students even after his retirement, because he is going to be around in Chandigarh. A brief introduction of Dr. Das. He joined PGI in 1984 as a resident, a trainee resident, and finished his MD in 87, then finished his senior residency in 1990. He joined as a faculty in the Department of Histopathology in 1990 and rose to the position of professor in 2008. Between 1997 and 1999, he went to UK for higher training, and he worked there in the North Manchester University Hospital, and he obtained his membership of Royal College of Pathologists in 1999. In 2007, that is after 8 years of membership, he was awarded fellowship of the Royal College of Pathologists. During his stay in PGI, Professor Das has contributed to the institute and to the department wholeheartedly. And to those who are on YouTube and younger people who may not know fully Dr. Das, I would also tell them that he has been very active in IAPM, that is Indian Association of Pathologists and Microbiologists. He has moderated several seminars, symposia, and always presenting some material in the conferences. He has been going around to different institutes to teach students. And he has been president of IAPM in 2007. In PGI, he had another feather in his cap by serving the institute as professor in charge of medical education cell, which he did superbly well. Now, please do not think that Dr. Ashim Das is a liver pathologist only. In our earlier careers at PGI, we used to chip in wherever anybody was required. So we, at least I can say, both of us used to rotate wherever there was a need. And I remember he did the dermatopathology, some neuropathology. Then he took over cardiac pathology. But I think after he came back from UK, his interest started in breast pathology, lymphoreticular, later pulmonary pathology and liver pathology. So these are his current areas of interest as well, and he's practicing in these areas. He has written several chapters and several articles, and his publications are about 220, and they are on various subjects. So what I'm trying to say is that his ICMR projects, if I correctly remember, they are on lymphomas only. So what I'm trying to say is that he is not a liver pathologist only. He's a full package of surgical and autopsy pathology. However, when I asked him in the department, when the department faculty decided to hold a CME, that what is his first love and what he would like to have as a CME, brief CME. So he said it would have to be liver pathology. So that is how we ended up thinking of doing a small CME in liver pathology. And by the time we decided, it was a bit late also to organize all these things. And therefore, we needed some speakers. And Sanjay Kakkad was here in Chandigarh those days. I requested him, and he was very kind to agree to us, and he's going to join shortly. Other thing which I want to say about Dr. Das is that usually people become reluctant much before their retirement. But I would tell you that in the last week, Ashim had a very busy last week, and he did a brilliant CPC. I saw him doing liver biopsy rounds. He took slide seminars, which we call softy slides for MD, for DM, and he yesterday, a day before yesterday, was speaking for PG trainings at that webinar, and so on. So he has dedicated his life for teaching. So I think that is why this idea of CME, that for a person who is in fully teaching, kind of his work is all related to teaching, we thought we will like to listen to him before he retires from active service in PGI. So I have invited some of his colleagues from clinical side and some liver pathologists so that we can have interactive sessions. So with great pleasure, I present to you Professor Das, who will deliver his lecture that is on an approach to interpretation of liver biopsy. And before I request him to give his talk, we would like to present him a small bouquet as a sign up from the Department of Histopathology to welcome him.
Thank you. Thank you.
So over to Dr. Das, please.
Thank you, Dr. Vishan and my friend. I must say that I am really overwhelmed by this gesture from him and from the department. And I must thank all of them from my core of my heart. So, as you have already understood that my really special interest to liver pathology. And I should say that I always tell my other colleagues that liver pathology is an art. One has to learn this art, then only one can interpret this. Because same liver disease can have a different morphology with a similar clinical approach. So I'm also thankful to all of my colleagues or friends from different parts of the world, and particularly clinicians, Professor Ajay Duseja and others, who will be interacting with me. In fact, I have changed little bit of the topic, although it is on interpretation of liver biopsy, but I thought that will be a little bit bland, so I just changed a little bit. Can we start?
Yes.
So I just say my topic is the amazing universe of hepatic pathology. This is not my really thinking, because almost 10 years back, Dr. Valery Desmet, when he have been told to write on a master's series in hepatology, he wrote about the amazing universe of hepatic microvasculature. I just took that clue from that article and I just changed it into the amazing universe of hepatic pathology. Why it is so amazing in hepatic pathology? Now, there is very characteristic features of normal and abnormal liver. Normal liver has got a diverse functions. It has got a vascular supply with a dual inlet, that is portal venous system and hepatic arterial system, and the outlet hepatic venous system. One thing which is very, very important in liver is that it has got a vast innate immune cells in the space of DC. In fact, the largest reservoir of the innate immune cells. And it is a seat of many systemic disease. In fact, my slide discussion will be restricted to these systemic diseases. How do we approach and what are the problem one can face and what is the most important part to really see in the liver biopsy. And in this setting also, I will highlight the diverse presentation of some disease. And here I will concentrate on autoimmune hepatitis, either acute onset autoimmune hepatitis, acute exacerbation of autoimmune hepatitis, and classical marker positive and marker negative autoimmune hepatitis. And then we have benign and malignant biliary disorders. But one thing which you see that the end result of all disease in the liver is fibrosis oblique cirrhosis, which ultimately lead to hepatocellular carcinoma. So one has to really concentrate on whether how much fibrosis or is there any evidence of cirrhosis in a liver biopsy. Even if it is not there, we should mention that there is no fibrosis. And in fact, in children, there are a large number of genetic diseases which are like progressive familial intrahepatic cholestasis, all will come into it. So let's see. I think I am just a case-based discussion, and that's why I want to involve clinician, particularly Dr. Ajay Duseja. So this is a 34-year-old female. You could see this is the history. It's a known case of celiac disease and hypothyroidism and TTPO positive, diagnosed 12 years back. Now found to have raised OTPT, which is 149, 162, ANA 1 plus, AMA weak with a hepatomegaly and mild splenomegaly. BMI is 26.9. But serum bilirubin is within normal range. Viral markers, anti-SLA, SMA are negative. FibroScan CAP value indicating more than 70%. S3 and elasticity evaluate liver stiffness and fibrosis F4. And she has got a gallstone of 2 centimeters and ultrasonography grade 1 fatty liver. So you could see the first half is basically a positive finding. And the second half, there are some negative finding. And the third portion is some investigation from the clinical point of view. Now, in this setting, can I ask Dr. Ajay, what was the indication for the liver biopsy in this setting? Oh no, he is not audible.
Yes, I can do it now. Yeah. Is it audible?
Yes.
I think so. This is a very nice case which you are presenting. I think female with at least 2 autoimmune diseases, which is hypothyroidism and celiac disease, which you said, and now coming with race transaminases. Immediately, I think we start thinking about autoimmune liver disease or autoimmune hepatitis. But then the confounder here is that on ultrasound and on fibroscan, you said that this patient had fatty liver as well. So the confusion which always comes to our mind is whether the rise in transaminases is because of fatty liver or is it because of autoimmune hepatitis. So if you look at, and she's non-alcoholic, so NAFLD, I think again there are certain indications for liver biopsy. So one of the indications for us as clinician would be that if there is any confounder and you are not sure about the cause of liver disease, whether it is fatty liver disease or autoimmune, I think for us that becomes a very important indication for liver biopsy. Uh, uh, I mean, having said that, let me just point out here that if you look at data on non-alcoholic fatty liver disease, there is data including from NASH, sorry, CRN group, that around 20% of these patients can have autoantibody positive, ANA positive or other antibody. So that is not equivalent to autoimmune hepatitis. We have to see it in clinical context. So if it is only ANA positive, normal globulin, no other autoimmune disease, we can pass it off like an epiphenomena. But somebody who's a female has two autoimmune diseases, globulins elevated, and if the IgG is also elevated, we can't ignore it. And there, I think we need to investigate this patient for autoimmune hepatitis. And I think that would be the indication for liver biopsy in this patient.
Thank you, Dr. Ajay, for your clarifications. So this was really indicated in this case, this liver biopsy. And when I went through this liver biopsy, it shows a fatty change which is more than 66% as compared to ultrasonographic estimation of grade 1 fatty liver. In fact, even I could not appreciate the zonation of the fatty change. This is very, very important. And if you see that in addition to that, no. Okay. This zonation, sorry, you could see that although there are more than 66% of the fatty change, one could see zonation which is restricted to the centrizonal area. Now, in addition to that, there are this type of lobular inflammation. I was little bit worried about that. There are lymphocyte and occasional eosinophils also. But there is definite lobular inflammation. But the most important thing, because we have to distinguish it from a whether there is no autoimmune hepatitis. Here, the portal tract is very innocuous, very mild inflammatory infiltrate. There is no irregularity. So a diagnosis of autoimmune hepatitis cannot be entertained in this biopsy. Now, the most important features is this ballooned hepatocytes. You could see that they are rounded and they are more than 3 times the size of a normal hepatocyte. And there are this calorie dengue bodies. All this will qualify for ballooned hepatocytes. So based on this, we thought we are dealing with a case of non-alcoholic steatohepatitis. But another important feature is that one has to assess the fibrosis. Now here there is a very mild pericellular fibrosis. In fact, some area there are linear type of fibrosis. So the fibrosis is very, very minimal. So based on this, and we have got some evidence of liver cell damage in the form of these macrophages containing lipoprotein-like pigment. Even it is seen even in the sinusoids. So based on this, we call it as a non-alcoholic steatohepatitis with fibrosis stage 1A and grade 3 fatty change. So my query is again from the clinicians, is there any discrepancy in the clinical findings from the histological features?
Yes. Okay. So I think the admin is, putting me on mute. Anyway, so there's no discrepancy in the sense is, as I said, the biopsy was indicated. Patient had fatty liver, raised enzymes. So if I forget for the time being the ANA and the other autoimmune diseases which she had, I think yes, the possibility of NAFLD with raised ALT, one of the possibilities would be NASH. The only problem, if I remember, on fibroscan, you had said that it suggested F4 fibrosis.
Yeah.
I don't know what was the exact LSM value, So if it was F4 on FibroScan and here you are getting only F1, I think that is the discrepancy, I would say. Otherwise, fat with NASH on biopsy, I think is acceptable. Except that, as I said, being having autoimmune diseases and uh, I don't know what was her globulin levels and what was the IgG levels. I think even if the AIH is not there, that is still acceptable, because we have had this earlier also, that because of the ANA positivity, we have done the biopsy and we ultimately turned out to be having only NASH. And as I said, ANA can be an epiphenomena in around 20% of these patients. But as I said, the discrepancy is in the fibrosis. So do we know the exact LSM value? You said it was
No,
F4.
I don't have any
Okay.
idea.
But that's the only discrepancy I would say. I mean, otherwise, I think this is acceptable. Yeah.
So that means one can have a pathological heterogeneity of the findings. So if we exclude that part, you just said that even we have grade 3 or the more than 66% area fatty change, but that is mentioned is grade 1 fatty liver in ultrasonography. There is also discrepancy in that.
Again, I would say the ultrasound is a subjective investigation. Would depend upon the ultrasonologist who is doing it. Somebody, it may be grade 1 for somebody, and the other ultrasonologist may call it as grade 2. So we don't rely that much on grading on ultrasound. More important then is the objective evidence again on FibroScan, which is shown by CAP, what we call the controlled attenuation parameter. So that's more objective evidence. And again, I couldn't see the value of the cap in this lady. So what was the exact value of cap?
So one thing which some group has stressed on that if we just report on NASH without mentioning about fibrosis, it doesn't have any value. Do you believe in that? NASH with or
Again,
without
so there's
fibrosis?
two schools of thought. Yes, I think ultimately the driver of fibrosis is also nothing but the inflammation. So the activity, what we call, which is seen by NASH, is equally important than fibrosis. And I will quote here one of the quotes by Professor Arun Sanyal, I mean, who's the master in fatty liver disease around the globe. He always says that the activity in NASH tells us that at what speed is the car moving. So, I mean, obviously the activity is going on. And the fibrosis tells us that how much distance we have already traveled. So
Okay.
fibrosis would be the end result, and ultimately the prognosis in fatty liver disease, or for that matter in any liver disease, and the ultimate outcome is dependent on the fibrosis. There's no doubt on that. But activity or the inflammation is equally important, because that's the driver for fibrosis.
Okay. Do you look for the what we report as a histological NASH, or you believe on the NASH criteria? I think even Dhanpad can take up
Yeah.
this. Yeah.
I think before Dr. Dhanpad takes it up, as a clinician, I think I would say, unless it is part of clinical trial where we will be interested in NAS score, whether it is 4 or more, and whether there are components each from steatosis, ballooning, and lobular inflammation. As I said, if it is part of clinical trial, because the entry points in clinical trials are very, strict. You have to have all these components, because ultimately you will do a paired biopsy later and you want to look at the improvement in all these components. But if, as a pathologist, if you just tell me NASH or no NASH without this, all the components, I think for clinical purposes that is fine with me. For clinical trials, I would prefer more of a NAS score. Yeah.
Can we come now? Comments from the pathologist.
Yeah,
Do
sure.
you follow Brandt's criteria for the initial diagnosis of a NASH? Anybody? Dhanpad?
Maybe can you hear me?
Yeah,
Yes,
we
yes.
can hear.
Uh, Thank you, Ajay, for your comments on the case, and I have some very brief comments. Number one, regarding the case itself, I think Dr. Das has been appropriately asking about the indications for biopsies. One other thing which I thought noticed was the patient has a history of celiac disease. And if you exclude anything else, also patients with celiac disease can have liver disease, which is neither autoimmune nor related to anything else, just related to celiac disease itself. So that by itself, with the raised enzymes and other things, becomes an indication for, I think, liver biopsy, which a lot of people don't recognize that some of these patients can present with advanced fibrosis upfront. So that was something interesting, and I think needs to be kept in mind, despite the fact that you still have fatty liver disease. I mean, they still could be both coexistent. Regarding the reporting of NASH in clinical practice, while we do mention all the features of NASH in our reports, we do not give a NASH score. And I think that's a practice in many places, because NASH score, as you appropriately pointed out, has been used largely for clinical trials for obvious reasons. In practice, NASH score has very little meaning, because NASH is such a disease with wide spectrum and requires so much of clinical pathology correlation that you really can go by a score. And the score is just a rough idea of something, but patients who do not meet the criteria for NASH based on the NASH score still need to be sometime managed as patients with active fatty liver disease. And so I think it requires a lot of clinical judgment, and the score by itself is not a clinically very meaningful number to do anything else.
You have answered our two questions from for pathologists. But there is an excellent article by Elizabeth Brandt, and she has shown that in so many occasions, with the findings of this three, more than four can be without any NASH. So that I think one it has come in hepatology, and she was quite really pragmatic about that. There is no scope for NASH in the initial diagnosis of in the NASH scoring system for initial diagnosis of NASH. So how often do you use ISC for the diagnosis of balloon hepatocyte, which is so important and critical for the diagnosis of NASH?
I don't know if you want me to answer. I see Siddharth has also sort of come onto the screen, so I'll let him answer also. Most of us, I will say that most of us do not use ISC to identify balloon hepatitis. It's like anything else. It's HNE diagnosis, and there are things which are called balloon hepatocytes, atypical balloon hepatocytes, and other features that sometimes indicate inflammation in liver biopsy without having balloon hepatocytes. So you have to put all those things together. And as I said, like, this is eventually still a clinical pathologic diagnosis. You cannot absolutely just put all the money on one finding or one feature in this case. And if you find balloon hepatocytes, it's fine. But if you don't, still it can be NASH, and still the patient may require management in NASH. And fibrosis is the probably most important finding in here, because people have shown in studies that balloon hepatocytes actually don't predict the progression of disease as much as the fibrosis. Fibrosis predicts fibrosis in NASH setting. So both questions, we don't do IHC for identifying balloon hepatocytes, and in terms of predicting disease progression, I think fibrosis still remains the most strongest predictor for progressive liver disease in NASH.
Okay.
Yes, and there's a known discrepancy between all the non-invasive methods of estimating fibrosis and histologic assessment of various things in the setting of NASH. So this is one area where often biopsies are performed and the clinical things don't match up with your other clinical parameters, or anything is not fitting right. You go for biopsy sooner than later.
I think just two points I would like to add on here is, see, the discrepancy of the fibrosis non-invasive, especially with FibroScan, or for even other non-invasive tests, may it be FIB4, NFS, or EPRI, is predominantly for, earlier stages of fibrosis, maybe for F1, F2. Once we call it F4, and if the LSM says, say, 20 or more than 20, and if it is suggestive of F4, I think the discrepancy would be little lesser. That is first comment. And the second was, which I think Professor Das was saying, that if you have a biopsy which is showing you a steatosis score of 3 and a lobular inflammation score of 2, So total you will have 5 by NAS, but then the pathologist may not agree that this is really NASH. So I think the NAS for diagnosis of NASH may not be really, you know.
Yeah, I think that is true. Even Elizabeth Brandt has stressed on this point. 3 plus 2, 5, but
5, yeah.
still it's not NASH
It's
according to
not
the
NASH, yeah.
present day definition. Let's go to the next case probably. We have learned something new. So this is another systemic disease. I'll just say that a 42-year-old male was diagnosed as a pulmonary sarcoidosis in 2014 on imaging and one biochemical test. I'm not sure on which biochemical test. And after 7 years, only recently in March, a liver biopsy was performed. Now, this is the appearance of the liver biopsy. If you see this liver biopsy, in this area there are this type of bland fibrosis, then surrounding that there are multiple granulomas, and in between also there is fibrosis. But this area there are normal looking liver parenchyma. If we come here again, this type of marked bland fibrosis is coming out in relation with this granuloma. I will come into this granuloma later. First concentrate on this bland fibrosis. You could see that there are numerous vessels are also there. And at the periphery, what we could see this granuloma. And this fibrosis is quite bland, and this granuloma, they are like a typical sarcoid granuloma, what we call it as a naked granuloma with multiple granulomas in the same space. And you could see these are all small granuloma in the same area, and they are surrounded by this fibrosis. And this is the epithelioid cells, and we really had to see whether there is any fungal profiles there or not. So we did not find anything like that. And this is the reticulin. Here again, this is the center also fibrosis, and the periphery also we could see fibrosis. And this is a smaller granuloma. You could see there are multiple granuloma inside the granuloma. All these are very characteristics of sarcoidosis. But again, it's a known case of pulmonary sarcoidosis. After 7 years they have. And now the most important part is this type of bland fibrosis. And there are at the periphery of this bland fibrosis, this is granuloma. And Mason's spectrum brings out this fibrosis much better. There is no ductular proliferation, and there is absolutely bland fibrosis, which is often seen in hepatic vascular disorder like chronic Budd-Chiari and others. And you could see there are some areas there are this type of longitudinal type of bland fibrosis. And this is all granuloma inside that. And there are small granuloma is developing in the same area. And this is a central vein. Here also this type of granulomas could be seen. But the portal tracts are essentially normal, bile ducts, portal vein, and there is no significant inflammation also. But one thing again, there are this type of dilated sinusoids could be seen. So, can I ask anybody who is a clinician that what is the indication of the liver biopsy and your expectation in this biopsy? Ajay?
Again, sir, I think if you ask me if somebody already has a diagnosis of pulmonary sarcoidosis, which was probably evident in this patient, because of you said she had pulmonary nodules, and the biochemical test I'm expecting is probably ACE levels, which must have been done. So based on that, if you already have a pulmonary sarcoid and the patient requires treatment for pulmonary sarcoidosis, and if you do the biochemistry, you may find elevated alkaline phosphatase. So which may tell you that patient could also have what we call the granulomatous hepatitis. And the reason for that could be, obviously hepatic sarcoidosis. So just for the documentation of hepatic sarcoidosis, we really do not require liver biopsy because the management would not change, because patient in any case is an indication for steroids or immunosuppression because of the pulmonary sarcoidosis. So just looking at the liver because of the elevated alkaline phosphatase, I think is not an indication for doing a biopsy. So the indication for doing liver biopsy in patients with hepatic sarcoidosis would be if you have a predominantly hepatic involvement That could be just maybe granulomatous hepatitis and there's no pulmonary involvement. Or if you have, say, it has progressed on to fibrosis, amounting to chronic liver disease or even amounting to cirrhosis or portal hypertension, and you really want to look at the cause for that. And obviously, you would then like to give steroids to the patient. There is an indication for liver biopsy. So in this particular patient, as I said, since the diagnosis of pulmonary sarcoid was already there and the patient was a candidate for steroids, and if just elevated alkaline phosphatase was there, I think we may not have done the liver biopsy unless there was some other indication. Say you, if you're not sure about the hepatic fibrosis, and tomorrow clinician wanted to take a decision that there is no response to steroids, and they were planning to give other immunosuppression, say methotrexate or something, and you wanted to look at the hepatic fibrosis. Otherwise, just for hepatic sarcoid, probably there was no indication here.
We have found there is a very extensive gland fibrosis. What could be the cause of gland fibrosis? What I thought, probably they are involving the hepatic veins, because if it is involving the portal tract, we may not have seen this type of gland fibrosis, and there would have been a bile ductular proliferation. But do you expect any specific clinical feature in this scenario if I say that this is probably involving the hepatic veins?
See, against the liver involvement in hepatic sarcoid, as I said, the commonest is the granulomatous hepatitis, where we see the elevated alkaline phosphatase. But there are three, four other, kinds of involvement of liver which have been described. The second one is what we call the cholestatic liver disease. So, which you said that the bile duct injury and all, and you can again have elevated alkaline phosphatase. The third is people have also described sinusoidal or a Budd Chiari like, picture. Fourth is the non-cirrhotic portal hypertension, and the last is cirrhosis with all its complications. These are the four, five, kinds of clinical involvement. So here I think it's the sinusoidal or maybe a Budd-Chiari kind of a phenomena which is happening, leading on to a non-cirrhotic kind of portal hypertension here, not really amounting to cirrhosis, and it's not a cholestatic disease, and it is not a
आंसर କରୁଛନ୍ତି ସାର୍ ଖାଲି କ୍ୱେଶ୍ଚନ ପଚାରୁଛନ୍ତି ତାଙ୍କୁ ଯଦି
Is
ବ୍ଲାଙ୍କ
there,
ଥିଲା କ'ଣ ହବ କିନ୍ତୁ ଆମର ଏଠି ଉଲ୍ଟା
okay, how common hepatic sarcoidosis progresses to clinical disease? Is it frequent or infrequent? Or how do you assess that?
Yeah, it's infrequent. So I think, as I said, I think if you look at all our causes of cirrhosis, I think this will amount to maybe less than 1 or 2% of cases of all our cirrhotics. So it's not a common cause of cirrhosis, but we do have patients on our follow-up, and to the extent that those who have decompensated requiring liver transplant because of hepatic sarcoid. So we do have cases on record, but it's not a common cause of cirrhosis. We do see non-cirrhotic portal hypertension also because of sarcoids, but the granulomatous hepatitis is the most common, and that is usually not an isolated liver involvement. I'm talking, if you look at all cases of pulmonary sarcoid, around 10 to 15% of them will have elevated alkaline phosphatase, and that is because of granulomatous hepatitis. That would be the commonest involvement.
I raised some questions. And as I mentioned, I believe this type of gland fibrosis is probably because of hepatic venous involvement. In fact, when I was talking with Dr. Ian Wanless, he also believed probably this cirrhosis following, or a secondary biliary cirrhosis following sarcoidosis, is probably overestimated. And I don't know whether this is right, Dhanpal.
I think that's very right. I mean, Ian Wallace is always right. I think the pattern of fibrosis in sarcoid is very interesting because it is different from many other patterns of fibrosis that we see either in chronic hepatitis or NASH or something else. The fibrosis generally follows the granulomas in sarcoidosis, and sometimes because of vascular involvement, it follows a vascular pattern. So I think the cirrhosis in sarcoidosis, whenever I've seen, it has been very, very heterogeneous pattern of fibrosis. and it does not, and sometimes the patients have portal hypertension without having classic cirrhosis with regenerative nodules, and like you see in chronic hepatitis. It is because of extensive fibrosis that follows these granulomas and sometimes involves the vessels also. And many times you have portal hypertension without actually having a classic cirrhosis on histology. So I am also intrigued by the bland fibrosis that you have shown, and that those look to me like areas of hepatocellular parenchymal loss, probably centrizonal areas, and for those, I mean, vascular would be one cause, and medication related prior injury or some exposure to something else could have been another one. But I agree, this is very interesting and probably related to vascular etiology. No, I
Dr.
don't know. I mean,
Siddharth,
Siddharth,
do you have
do you have any other
anything to
thoughts?
add?
You are there as well. So,
I think actually unbiased, I also thought this was a vascular phenomenon, just like Ashim thought. And sarcoidosis, as you say, is generally bland fibrosis. And of course, when it obstructs the bile duct and all, then you get the other lot of inflammation and other things coming. In this case, particularly, I would request Ajay if he has done some imaging studies to rule out any venous obstruction because it was centrizonal
Not
as
his
it looked
case,
like.
it is common.
And
The,
uh,
yes,
and in
not his.
fact, it's been reported. Rarely
Yeah.
sarcoidosis does cause butt carry like.
But carry like picture. Yes, it has been reported. Yeah.
Okay, then we'll go to the third case. So I think one should not write only sarcoidosis, they should write the extent of fibrosis in all this. I mean, there is a tendency to call just sarcoidosis and leave it like that, whether the fibrosis. So in all liver pathology, this should be the mandatory. Whether there is even if there is any no fibrosis, also you should mention that there is no fibrosis. Okay, then the third case, which is really complicated, and because of COVID also it progressed from February 2020 to only the recently, just in March 2021. So it has got a progressive cholestatic jaundice in a 40-year-old male with a fever and loss of weight. And they have found that there is a diffuse lymphadenopathy, tree inward appearance in lung, hepatosplenomegaly, and underwent this FNAC from paraiotic group of lymph node granulomatous inflammation. And in that time, ERCP has showed cholangiogram with minimal contrast, dilated right ductal system is structured at hilum, left ductal system could not be opacified, brass cytology taken. Again, there is a stenting done in the right ductal system. Now, course and management, this is just before last COVID, and patient admitted under surgical services for left hepatectomy. But as there is a diffuse lymphadenopathy and there is the IgG level was 5.12 gram per liter, and CA level is 370, CA 199 level is 376. So they thought could be related with IgG4 related disease, and without any, of course, then there is a high grade fever, ultrasound dilating left biliary system. Again, they put stenting in the left ductal system. Because of this IgG4, high level of IgG4 and granulomatous lymphadenopathy, they in this setting they thought that they will do a liver biopsy, whether liver biopsy can help anything or not. That was in 9th March this year. That is 1 year after the COVID onset of COVID. Now, Uni's diagnosis was a hilar stricture, generalized lymphadenopathy, post ERCP and stenting of right ductal system, post PTVD of left ductal system, portal hypertension, chronic liver disease, secondary biliary cirrhosis. He was on long-term steroid therapy because of that thinking of that this could be IgG4 related disorder. Okay, now at this stage we got the biopsy. This is in the recently only 2-3 months ago. And you could see that there is extensive fibrosis. Almost half of the liver biopsies shows only bland fibrosis and half are relatively normal. And but in this, at the end of this fibrosis, you could see this granuloma. And this granuloma shows central necrosis, but there are periphery, there are this granuloma. So general tendency, even FNAC has also shows in the first pre-COVID smear that there is some granulomatous inflammation. And this is the some granuloma could be seen, but side by side there is extensive fibrosis, which was creating problem with a stricture, and for that they had to do, in fact, stenting in the both ductal system. And this is the area of sclerosis. And this is the area where there is a normal looking liver was there. This is a granuloma which you could see, but while seeing it under the microscope, we realize that there are some organisms could be sitting in this area. And this is the small granular epithelioid cells are there. One thing which is also really put me into that, that this eosinophils, that I thought that we should look out for some fungus. Then we did PS Alcian blue, we could see this type of organisms which are quite compatible with the diagnosis of a cryptococcosis. Even PS with dust is also shows the similar features. Some are in, most of them are inside the macrophages. And even the small types of this yeast also could be seen. So this one we thought, in addition to that, there is very extensive fibrosis by this time has occurred, because he has delayed almost like a 10, even the more than 1 year. And here also there are unstained some cryptococci could be seen even in this special stain. Even the retic shows lot of fibrosis. And this is the granulomatous area. So basically what we have seen, cryptococcosis of the liver with extensive fibrosis of the affected region in immunocompetent settings. Although he was taking steroid for a low dose for a long period of time because of to exclude IgG4 related disorder. So comments from the, any comment from the clinician? Ajay?
I think it's I would say a difficult but equally interesting case scenario. We really, I mean, in an immunocompetent setting, and then to have a cryptococcal liver involvement would be, I would say, uncommon. Not saying that it is not described. It is described, but then what was his HIV status, sir? Do we know that?
Yes, it was normal, no, negative.
So HIV negative, and as you said, the only immunosuppression that he was on steroids, so that can make him, immune compromised. So that was probably the clinical setting, I would say. Then coming to the liver and the bile duct involvement in cryptococcus, again, not a common phenomena, but yes, people have described, mass-like lesions or biliary strictures or the bile duct involvement because of cryptococcosis, and people have shown these organisms in ERCP brushings and all. The liver involvement, again, people have shown, cryptococcus in the liver also. But as I said, it's an uncommon phenomena, usually described either in HIV or other immune compromised states, or in patients those who are post-transplant, maybe say post-liver transplant or post-renal. So I think that is the kind of clinical setting. But yes, if you ask me the involvement, this kind of involvement, which can mimic even cholangioCA, could mimic what we call the sclerosing cholangitis, which can mimic, IgG4 related disease. Everything, has been described with cryptococcosis, the bile duct involvement. Now, the liver involvement, I don't know how to explain this extensive fibrosis because of cryptococcosis. I think I have no explanation for that. So I personally feel that all fibrosis, if it is fitting morphologically into that, could it be all, his IgG4 diagnosis probably was not right because he did not respond to steroids.
Yes.
Had it been IgG4, especially, the type 1, he should have responded to steroids. The fact that he did not respond to steroids, I think he was probably not IgG4. So whatever was his biliary disease, that probably could be leading on to secondary biliary fibrosis, I feel. And cryptococcus was, just maybe a, opportunistic infection which has occurred, because of the steroids which he was taking, and may not be the real culprit for his, even the bile duct stricture and the liver involvement. This is what I personally feel, yeah.
Yes, I think this is little bit difficult to really correlate with the cryptococcosis, but that is the only thing which is available at present. So we don't have any other way to go away from that. So let's see now. Any other query from anybody? Okay, then I will just go into this. The theme of this two slides is that the many facets of a single disease. I am always intrigued by this. Why we see in a different types, different biopsy of the same disease with a different type of morphology. And this is the first one, which is a 10-year-old female child who has got a diabetes mellitus on insulin. Father is also a type 1 diabetes mellitus. 3 episodes of jaundice at 5 years of age. And he had this mild icterus pallor, no peripheral stigmata of chronic liver disorder, but spleen is 5 centimeter below left costal margin. And he has got a AST, ALT is 466 and 224. GGT is 88 and IgG was 6190. So that is raised, and ANA, ASMA, and ALKM and extended markers all are positive. Ceruloplasmin was nearly normal. All viral markers are negative. But the clinician thought this could be a suspected autoimmune liver disease. Now, is there any features which is against the clinical diagnosis of autoimmune hepatitis, Ajay?
Not really, sir, because I think a young female, I mean, we see more of, type 2 autoimmune hepatitis in children or young adolescent, but then she was positive for all ANA, LKM, and everything you said. Enzymes elevated and IgG is hugely elevated. You said 6,000, which is, very, very high. I'm pretty sure the globulins must also be elevated. So ANA positive, elevated enzymes, young female, autoimmune markers positive, IgG elevated. I think we can't go away from a possibility of autoimmune hepatitis. So I think we have to keep that possibility.
Is it any particular type of autoimmune hepatitis you think, or is it just a common garden variety of autoimmune hepatitis?
And the other point which was in favor of autoimmune was the negative viral marker. So as I said, we normally in adults or young females, in general, it's the type 1 which is more common. But in children, people have described, type 2 as more, which is LKM1 related. So, and the gamma GT, if I thought was, I think, near normal or minimally elevated, I couldn't see the alkaline phosphatase. If that was also normal, so it was predominantly a hepatitic illness. So I can put it as either type 1 or type 2, either of the two autoimmune hepatitis.
Okay. Now just see, this is a biopsy in this particular case, and we have these portal tracks are irregular, and you could see that there are a lot of inflammations are there, and you could see this is really the centrizonal area. You could see that this is the centrizonal area where there is a loss of hepatic parenchyma, and in this there is in some area there is a perivenular fibrosis. Even this area also there are plasma cell infiltrate. Even other areas there are some lobular inflammations. This is the area of lobular inflammation, but everywhere there is plenty of plasma cells, and there is a relative paucity of inflammatory cells in the portal tract, which I believe that this is little bit odd for a usual autoimmune hepatitis. And this is an area where there is a apoptotic cells and there are this plasma cell infiltrate within the liver parenchyma. You could see that there are some degree of you are right that this is looking more like a hepatitic rather than the usual. And if you see all the centrizonal area, they are quite bland and they are infiltrated by these plasma cells. Here again, we could see that there are a lot of plasma cell infiltrate. Mason's trichome brings out this fibrotic portal tracts. They are not that irregular like we see in autoimmune hepatitis, but centrizonal area seems to be a little bit different as compared to, even if you see this portal tract, they are not very irregular. To really call it as a usual autoimmune hepatitis. And this is another portal tract area. Here, of course, we see a lot of plasma cell also. This is that area which I was talking about, that there are this type of hepatocytic loss and there are this plasma cell infiltrate. As there was a lot of plasma cells, even there is a clinical suspicion whether could it be IgG4 related disorder. So we did immunohistochemistry, but it was not very, because at the background all are essentially plasma cells, but then only very few are the IgG4. So we really could not put it into IgG4 related disorder. And you could see that there's very few IgG even in the lobules also. So this biopsy shows really lack of portal pathology, but there is a significant centrizonal pathology. And this is not really correlated with the this any IgG4 plasma cells. So as I just wanted to know from a clinician, is it definite AIH in the revised? Can you put it into revised definite AIH in the revised international autoimmune hepatitis group without any significant portal tract changes, or in a modified scoring system, or a simplified diagnostic criteria for autoimmune hepatitis?
See, I think if you have to score this young female, obviously she gets marks for viral markers being negative, ANA or other markers positive, IgG elevated, so she gets all the marks. Now, if we have to add histopathology, so histopathology can be, sometimes we say it's consistent with AIH, or we can say it is against AIH, or we can say that it is definitely AIH. So I don't know, you probably have to tell me, is it consistent? So it doesn't look to be, in the sense, the type of cells and the interface hepatitis are suggestive. The only thing is the inflammation is not that dense, and it's more of centrizonally, as you said.
Yes.
So that would be little odd. So it may not be consistent with this thing. But if I have to take the help of liver enzymes, IgG, autoimmune markers, I think even without biopsy, as I said, our first possibility would have been AIH only.
But it will not cross 16 in that criteria.
So then
For
the
a
only issue
definitive
would be,
AIH.
sir, what would be our alternative, possibility, viral markers negative, everything negative. So I don't know whether pathologically, whether this kind of phenomena, predominantly centrizonal, has been described or not. I'm not sure on that. Professor
Let
Vedasingh
me,
is also there. Maybe we can have comments from him.
Yeah, so just going to say that first of all, criteria are just meant to be guidelines. Criteria are these numbers I said for NAS and for other things also. Really, I mean, one should not just always blindly follow the numbers. They are just meant to be helpful, and they're broken in every possible situation. So besides that, I think this pattern of hepatitis that we are shown with autoimmune hepatitis, with either centrizonal pattern or sometimes more lobular pattern with less portal inflammation, has been described and not addressed in the older scoring systems as being typical of autoimmune hepatitis. So Sanjay is also, I think, I joined. We have been part of an international working group now, which has addressed this issue and included these two new patterns of autoimmune hepatitis, which include both the centrizonal predominant inflammation as well as lobular pattern, and many of them present sometimes more clinically as acute hepatitis, also some acute or subacute hepatitis. So those will be addressed in this new international working group, histologic criteria for autoimmune hepatitis. So I don't have any doubt based on what Ashim Das has shown, that this is very likely an autoimmune hepatitis, and whether it meets the criteria by numbers or not, to me, it doesn't matter. I mean, this needs to be treated as autoimmune hepatitis. And this is autoimmune.
Yes, I also believe that this is whether you wanted to give a name, acute onset autoimmune hepatitis or acute exacerbation of autoimmune hepatitis, that is it. But for acute exacerbation, we need to have either previous biopsy diagnosis or clinical diagnosis of autoimmune hepatitis.
Well,
But
histologically, you have fibrosis. I think that itself is suggestive of this is an acute on chronic kind of a disease. And for autoimmune hepatitis, probably that kind of classification for pathologists doesn't matter, because autoimmune hepatitis is believed to be, a priori a chronic disease. Although you can have acute manifestation, you can have acute or chronic presentation, or sometimes chronic presentation. So those can vary, and based on the clinical and pathology, you can combine to say that this probably is acute exacerbation of a chronic disease in this case, because you have substantial fibrosis, as you showed on trichrome stain. It's almost going into bridging fibrosis. So I think some of the terminologies may be a little bit arguable as to how you apply them, but I think there's a lot of scope of variation.
This is also we have observed in our autopsy material. I have seen the kids which are having a very, very significant centrizonal pathology. They just progress like, and this is our, at least my experience, even my colleagues' experience in this, that young females, these children, when we have seen in the autopsy, they are showing very significant features of centrizonal pathology. So that's why my really request that is that liver biopsy must in this type of settings when you will have a very high AST, ALT, or in an acute event, that should be probably a liver biopsy, indication of a liver biopsy. Varinder Singh, you are here.
Yeah. See, the problem is that it fits into the autoimmune hepatitis only, but rarely what happens, we put them on steroid and then they develop sepsis, then we are at a loss. So to avoid that, it is always better to have a histopathology. As in this case, although everything is fitting into autoimmune hepatitis, but the biopsy is not that much sensitive of the autoimmune hepatitis. So we'll have to be a little careful, but we will treat this patient as autoimmune hepatitis only.
So the one point I would like to add about the acute presentation, I think 25% of all autoimmune hepatitis will present acutely, and they do present like acute hepatitic illness. And as said by Dr. Dhanpat, I think even if they have underlying chronic, the presentation is like an acute hepatitic illness. Many of them do present like acute on chronic liver failure like phenomena, or some present even like acute liver failure also. So that kind of clinical presentations are well known, but the point is when we do liver biopsies in them to make a diagnosis, we usually have, a portal disease which is predominant rather than the centrizonal. But then I think as has been pointed out, this kind of, phenomena has been described. So I think that's the only point I thought I'll make here.
Yes, Dr. Sanjay Kakkar has also thought that this type of phenomenon is well known and it has been described in autoimmune hepatitis. So there is nothing against calling it as autoimmune hepatitis. Even I also thought this is autoimmune hepatitis. My apprehension is that whether anybody has followed up this patient, whether they progress very fast to a classical autoimmune hepatitis, or they have produced a lot of fibrosis in the liver. That is my query.
So the only other point is between the type 1 and type 2, this is again described that the type 2, which is described in children, that's usually they can present with more severe disease, more of fibrosis, more of cirrhosis, and they can have little more aggressive course in comparison to type 1. So I think that could be one reason. Yeah.
So this is for pathologists. Can we still diagnose autoimmune hepatitis without the presence of classical features? I believe yes. I don't know what about the other people. If we exclude, of course, there is no drug intake. Drug intake can cause centrizonal necrosis, but they don't produce that amount of plasma cell infiltrate. So if they are taking alcohol, but these are all the young children, they really suffer this type of problem. But I believe that, I think, what about Sanjay and Dhanpat and Siddharth?
I think this has been well described. It is rare, but for follow-up, some of these have been shown to transition to portal predominant disease and develop typical features. But as you mentioned, because of centrizonal predominance, the drug really has to be excluded first, because these are relatively uncommon presentations.
Do you believe this type of people progress very fast, which I have observed in our autopsy material? that I have seen those children or young adults, they are in autopsy table, their liver shows this type of centrizonal pathology much more than the usual autoimmune hepatitis which we see in a elderly people or a middle-aged female. And is it been described by anybody or no?
I have not seen it, and I've not seen it being described any rapid progression specifically for centrizonal predominant AIH.
Okay.
But some of the cases that we have encountered, many of them don't have adequate follow-up to answer a question, Ashim does, but they tend to have a more severe clinical presentation at the first. They more often present with severe acute hepatitic-like illness or acute on chronic disease with clinically what looks like either a fulminant course or very severe presentation. And Sanjay also mentioned in his chat, and this is another thing that people probably need to be aware of, that some cases of autoimmune hepatitis that are both central or lobular presentation or lobular inflammation as opposed to predominant portal inflammation may sometimes have not so many plasma cells also. I've recently seen a couple of cases where the number of plasma cells are not as you shown in this case, and clinically they may not meet all the criteria for autoimmune hepatitis, with either auto antibodies being negative at the early stages or the IgG levels being not so high, and still they respond clinically like autoimmune hepatitis, and on follow-up biopsies either develop a typical autoimmune hepatitis like pattern, or at least initially respond to clinical management like autoimmune hepatitis. So there is a subgroup which has this atypical presentation, and clinically I think the most important part is to exclude the main differential diagnosis, which is DILI, and rarely some other unusual infections or something else. So I think this is a very nice case, very educational, and I think highlights a very.
Yeah, Dr. Ashim.
There is a comment. Hello, there is a comment
Yeah.
from Dr. Bush. I'll just read it out. It's on YouTube. He just says, Dr. Bush was also our teacher, and he was also a liver pathologist. He says, maybe it's time to relook at the old term prevalent during our times decades ago, chronic active hepatitis of autoimmune variety. Just the experts can comment on that.
I think this terminology, chronic active and chronic persistent hepatitis, has been really abundant. And people believe that the most of the so-called chronic active hepatitis in our time, 90s, may be features which are either isolated autoimmune hepatitis or may be associated with chronic hep C. I think that's why it is true that autoimmune hepatitis can be diagnosed only based on a significant interface hepatitis with significant portal inflammation, even there is a background of chronic hep C or any other features. So that's all right, I think. So how much do you really give importance to these plasma cells? You don't diagnose autoimmune hepatitis without having plasma cells in any of this?
You're muted, I think.
You need to unmute yourself.
I think, Ashim, nowadays people have seen in many cases that it's not necessary that always you'll get plasma cells. Some studies have counted only up to 30 to 40% in day cases. It's not necessary that always you have 100%. The other thing is, there were some hepatic rosettes which are considered to be important in this case. There was
We can discuss this when we are at the second case, next case.
Okay. Ashim, the other thing which Ganpat made, I think that's very important. We should not go just putting numbers and trying to make a diagnosis.
Yes.
Once you make the diagnosis, then you can add. In fact, if you take the original international autoimmune liver disease criteria, if you are a female, you're 2. Okay. Then, for example, if you have got normal globulins, then you add another 1. Then, if you are not an alcoholic, you add another 2. So you get 10 points. Anybody who is a normal female will be a probable autoimmune anyway. Without viral markers, another 2 you add. So like that, it adds up to 10. even in a normal female. So that is why I think this is very important. People should not just add numbers and make a diagnosis. Whether it is
Go to
NAS,
the
whether
next
it is
case, and I think
To this, there is just a comment by Dr. Madhumita, who is a clinician in PGI.
these are the comments actually.
Yeah, you should paste it up there. So that they
Can we discuss it after this case? This is also the same way. We'll just discuss after this.
Sure.
Huh? Okay.
We have
Timing. Okay, this is a 38-year-old female with history of hypothyroidism, Sjogren's syndrome with transaminitis, OTPT, 46 and 43, IgG level is 29.7. So this is a typical history of a autoimmune hepatitis. And this is a biopsy. Here we could see that, you could see that there are portal tracts are again quite bluish, and in this low power, and there are irregularity of the portal tract. Here also this is irregularity of the portal tract. But when we see these portal tracts, they are having interface hepatitis, but they are not like the way we usually see in the classical autoimmune hepatitis. But side by side, there are this centrizonal area. Now, this is another portal tract area where you could see this type of rosetting of the hepatocytes, but there are no significant plasma cells, but the lymphocytes are plenty. And this is the area where we could see this type of rosetting. And this is a rosetting, and we thought this is there are some plasma cells, so this is quite fitted to the interface hepatitis. So this is a portal tract based changes, and there are these other types of infiltrate. But in that biopsy, we could see again this type of centrizonal pathology. You could see this is that area, and there are again these plasma cells. And there are several centrizonal areas shows this type of changes with lot of plasma cell infiltrate. And there now we could see these plasma cells, and there are some damage to the hepatocytes. And there are this plasma cell infiltrate. So in this we could see both portal tract changes, but with a very, very prominent centrizonal pathology also. And this type of condensation of reticulin could be seen. And in some area, centrizonal area has got this type of condensation. There are also very thin layer of centrizonal hepatocytic necrosis with condensation of reticulin. And Masson's trichome brings out this area also better. This is centrizonal area with lot of changes. And again, there are a lot of plasma cells. This is the thing which we are observing, that whenever there is any centrizonal hepatocytic necrosis, this plasma cell infiltrate, even if you may not see in plenty in a portal tract area, but you could see a lot in the centrizonal area. So this is the Masson's trichome. This is the portal tract area which is irregular. And again, this is some portal tracts are relatively normal, but the other areas their irregularity is there. But again, this centrizonal area shows this type of pathology with the necrosis with condensation of, I will show you in the retic. And this is the centrizonal area with lot of hemorrhage, indicating that this is more fresh than the, again, there is condensation of reticulin here. You could see that there is this type of condensation of reticulin. And there are evidence of this portoportal bridging fibrosis also. This is another centrizonal area. So basically what we are seeing is that this is a classical autoimmune hepatitis, but with having a centrizonal hepatocytic necrosis. But if you see the OTPT, they are very low. They are lower like a. So how do you explain? And that is a comment from clinician I want. Is there any explanation for low OTPT values in this type of autoimmune hepatitis with centrizonal hepatocytic necrosis?
I think this is what I was going to comment on. Autoimmune hepatitis, like chronic hepatitis B, is one condition where we have a good correlation between the liver enzymes and the liver histological activity. Unlike, we don't see that kind of good correlation in, say, NASH or chronic hepatitis C. So here the AST, ALT being near normal and then to have this kind of activity is uncommon, but can happen, and rather this becomes an indication for us for treatment that even though the enzymes were normal, And if you do get moderate to severe activity like this on histology, patient becomes a candidate for treatment. So as we said, I think on AIH, we always rely on histology. And I think if the liver biopsy shows us activity like this, even though the ALT was normal, we would like to treat this patient with immunosuppression.
Okay. Now, before I conclude, I just wanted to see some chat. Can you see this?
Yes, I can read for you. Dr. Madhumita is asking
Hmm.
how to differentiate drug-induced changes in the setting of IAH, because the treatments are different, I think, duration-wise.
Yes, this is a very, very important area even for a pathologist. So if we see centrizonal hepatocytic necrosis in addition to a typical portal tract-based pathology, one has to exclude the history of drug intake. One thing which is not seen in drug-induced centrizonal hepatocytic necrosis, very significant inflammation will be missing. But even these are all just anything can happen, but we have to exclude a possibility of a drug-induced centrizonal hepatocytic necrosis in all settings. Otherwise, it will be very difficult. Plasma cell infiltrate may help in that type of situation where less number of inflammatory cell, more help in the drug-induced centrizonal hepatocytic necrosis. This is a very, very difficult area probably. Anything?
Then I think Dr. Dhanpal Jain has mentioned to everyone that few eosinophils can be seen with almost anything.
Yes.
Including AIH, HCV, HBV,
Yeah.
or rejection. When they are prominent, one certainly needs to consider other conditions, particularly DILI or other infections, because I think Madhumita, somebody had asked, Dr. Malini had asked about this question. So
I will concentrate probably more on a lack of significant inflammation, which is seen even in acute drug-induced hepatitis. That people say that the lack of inflammation is a feature of a drug-induced because there is a direct cytopathic effect. That's why you don't see much inflammatory cells. So I think we are at the end of the. So I must conclude that liver can be involved in a variety of systemic diseases, which I showed you, and ultimately can progress to fibrosis and cirrhosis. And there can be multiple clinical and pathological features of same disease like this enigmatic disease, autoimmune hepatitis. But one thing which is always true that pathology should always comment about the fibrosis in details along with the original diagnosis. We should not write just autoimmune hepatitis without, even in the final line, should talk about the fibrosis. So I must thank all the participants, particularly clinicians, Ajay, Varinder Singh, Madhumita, and pathologists. Those who have commented, I can tell their name, Dr. Siddharth, Dhanpat, and Dr. Sanjay, even Dr. Bush. Really thank you for all your really participation in this. Thank you very much. I think now I will hand over to Dr. Vishen.
thank you, Ashim. Wonderful, wonderful. I must say that you have so much to teach, and this was a great exposition. And I again reciprocate my feelings to thank Professor Virender Singh and Ajay for Madhumita has also joined. So Ajay, thank you so much for making it an interesting interactive session. Sanjay, good morning, and I would like to thank Dhanpat for his extensive kind of comments, and Siddharth and Sanjay. So thank you very much. We had a very nice session. I thought it would be for one hour, but it has gone on. So now I think we move on to the second lecture, which is to be delivered by Dr. S. Datta Gupta, our great friend Siddharth. He is known to almost all of us. The only thing is that I think needs for those who are younger and maybe participating on YouTube, they need a little bit introduction. Dr. Siddharth Datta Gupta is a very humble, simple man. These are his humble and humility and simplicity are his great attributes that I actually admire. He's a very dedicated and inquisitive pathologist, always raises queries, always there in discussion. He graduated from Bangalore, and then he did his MD from Institute of Medical Sciences. After his MD, I think he has a brief stint at St. John's in Bangalore, if I remember correctly. Then he joined as faculty at the All India Institute of Medical Sciences. His main area of interest has been gastrointestinal and hepatobiliary pathology, and he had served brilliantly and to the satisfaction of all these two departments, that is gastroenterology and hepatology. I know people are great admirer of Dr. Gupta. He had a special training in liver pathology at the Royal Free Hospital School of Medicine, London, during his career in All Institute of Medical Sciences. He is very popular among his MD students. I think he has guided many MD, DM, as well as PhD students. And the other thing about him, I would say, is he has left a wonderful legacy behind him. And one of his students who may be online, Dr. Prasanjit Das. Well, we claim that he's our student and they claim that he's their student, but Prasanjit Das has always been facing this kind of where he belongs to. So, but anyway, I now say that he has trained him very well, and he's Prasanjit is a person who has replaced him. Dr. Datta Gupta also served All Institute Medical Sciences as Dean Examinations and left a very good mark as far as his dedication was concerned. He served as secretary at Indian Association of Pathologists and Microbiologists, and everybody remembers his good services. In fact, people still remember and have a lot of appreciation. Then following that, he became president of Indian Association of Pathology and Microbiology. He has recently retired from AIMS, but he is still in active participation of academic things. I think his lecture is an approach to cholestasis in liver biopsies. So I hand over the proceedings to, I present Dr. Gupta to you and hand over the proceedings to him. Siddharth, please.
Thank you, Dr. Vishen Radotra. Thank you so much. Can you see my screen now?
Yes,
Yes.
Okay. Right. Dr. Radotra has been very kind. It was almost like my farewell he was speaking on, rather than Ashim's. It is today's Ashim's day, and the entire thing belongs to him. Actually, this topic was chosen by Ashim himself. And I must tell you that he is the master of cholestasis, not me. And so I've kept it very simple, and let's see how it goes. So this is actually today we have come here to not actually bid farewell, but to congratulate Ashim on his brilliant career. And this is only part of one innings. I'm sure he will have a greater innings later, and he'll continue to educate all of us. It's been wonderful, and he and Radhika have been excellent hosts. You know, Chandigarh, I never feel that I leave Delhi when I go to Chandigarh. All of them are so nice. In fact, I have had dinners probably in most of the faculty members home, me and my family, and Radhika and Gargi are excellent people and excellent hosts. So Ashim, I will continue to indulge in your house whenever I come to Chandigarh and continue to listen to you. And I'm sure people will remember you lifelong, and all of us, of course, will do and continue to help people in Chandigarh. And I hope you'll find more time to travel and educate all of us. So with this, Ashim, this is just like a small presentation for you. It's nothing great, nowhere compared to what you presented today just now. So I'll be talking about cholestasis in general. So this is, if you see the biliary tree, this entire cholestasis is mainly about one aspect of the liver that he talked about. that is the large bile ducts, which are predominantly, as a rule of thumb, mostly outside the liver. And then you have the smaller bile ducts within the liver and in the portal tracts. And then you have the canaliculi. This is roughly in brief. And so you see from the larger ducts, there's almost a hierarchical distribution in which the lumen narrows until it reaches about 1 to 2 microns, which are the near the canals of herring. You have the canalicula, which are 1 to 2 microns, which are nothing but two faces of the liver cells, which just join together and then form this canalicula. So, but it's important to note that in addition to conduction of bile through the biliary tree, they also absorb a lot of elements in the what is present in the bile, and they are also the stem cells of the liver. In fact, whenever there is liver damage, you find a lot hepatocellular damage. Find a lot of these cells of smaller bile ducts near the canals of herring, which multiply, and it's not necessarily because of biliary disease. They actually go there to replace the hepatocytes. You find them in many cases of subacute or panlobular massive necrosis, at least trying to replace some of the liver cells. Okay, so from 800 microns, they reduce to about 1 to 2 microns. It's the other way actually. From 1 to 2 microns, it goes to 800 microns. And it's almost like a countercurrent mechanism. The blood flows in the sinusoids from the portal to the central area, whereas the bile flows from the central to the portal area, okay, to zone 3 to zone 1. So this is how the liver cells are. And you need not always do a immunohistochemistry to identify the canaliculi. By and large, you can see them in H&D sections, and it's only on rare occasions that you will need the H&D. They are the larger ducts. In fact, if you do a PAS staining, they stain well the surfaces. Then you have the segmental area, septal ducts, interlobular ducts, small ductules or cholangioles, canals of herring, and then the canaliculi. So you have the minimal bile secretory function and the minimal bile salt uptake in the centrozonal area, and it goes in the increases maximally in the periportal area, both the secretory as well as the bile salt uptake. So this is very important. It is responsible for some of the morphological changes that we see. Now, what is cholestasis? Cholestasis means different things to different people. So if you see it from a point of view of physiology, is the impairment of bile flow and failure to secrete inorganic and organic constituents of the bile. To a clinician, it's indicated by jaundice and pruritus. If you go to the laboratory, it's an elevated serum bilirubin, elevated bile salts, alkaline phosphatase, gamma GT. And for histological tissue sections, when you see, it's the visible manifestation of bile salt and bilirubin uptake, transport, canalicular secretion of bile contents. Normally, in the canaliculi, you'll never see bile. The moment you find bile within the canaliculi, it is abnormal. Okay. There are various host of causes for cholestasis in adults, but the predominant thing is that whether it's in the large duct or the cause is in the liver parenchyma itself, the portal tracts and the biliary tract. So the larger ones are mainly mechanical causes or obstructive causes to bile flow. Gallstones, malignancy, stricture of the common bile duct, and so on and so forth. There are certain biliary diseases like primary biliary cirrhosis that manifests mainly within the liver, primary sclerosing cholangitis, in which you get obvious abnormalities of the bile ducts seen by imaging. Then, of course, there are graft versus host disease, loss of bile ducts, so on and so forth. The non-obstructive causes for cholestasis, there is no mechanical obstruction as such by way of to the flow of blood of the bile, except perhaps when you have hydropic change, it's quite likely that the enlarged hepatocytes can block the canaliculi. That might be one of the reasons. But the non-obstructive causes are predominantly infectious, toxic, because of various inherited diseases and various other causes such as the intrahepatic cholestasis of pregnancy, infiltrative disorders, and so on. But please remember, one of the common, often misdiagnosed and undiagnosed cases are drug-induced cholestasis, because drug-induced liver disease can mimic anything and everything under the sun. So currently, cholestasis, because the main difference that you have to make out is whether there's a mechanical obstruction or not. See, the cholestasis is therefore evaluated predominantly by clinical evaluation, by certain laboratory investigations and imaging techniques. Imaging techniques along with the laboratory and clinical evaluation are so good that even with an MRCP, approximately 94 to 95% of the times you're right in detecting whether there is a biliary obstruction or not. But by and large, the mainstay is, of course, ultrasound as the first line of this. So the role of biopsy is gradually getting limited in identifying the difference, whether it's large bile duct obstruction or a disease of the liver parenchyma. On the other hand, the liver biopsy helps in establishing the etiology, especially if it is intrahepatic in origin. Okay, so you have non-suppurative cholangitis, storage infiltrative diseases. We saw a host of autoimmune diseases and so on and so forth. So please remember, the first line of evaluation is whether there's a mechanical obstruction to the biliary tree or not, and then of course try to find out the etiology. So general algorithm is you find out what the lab findings and the history, physical, clinical examination is. All patients, whenever they suspected cholestatic disease, will undergo an abdominal ultrasound. And if it gives a reason, then well and good. Then, of course, then you have other investigations, special investigations like AMA, ANA, and then for PBCs, you have other investigation, the antibodies. They will also help in establishing the diagnosis along with the ultrasound physical examination. If these do not give the answer, then you have extended imaging. Nowadays, the ERCP has by and large been replaced by the MRCP or magnetic resonant pancreatography, which detects most of the cases of sclerosing lesions or any other obstruction. Then, of course, you have liver biopsy, and additionally, especially in the pediatric age group, which we'll not be discussing today, are genetics and other things. Then, of course, there'll be a small proportion. Whatever you do not know the answer, but you can arrive at a probable differential, and then you observe and re-evaluate after some time. So this is the general feeling of how you identify these cases. Imaging, of course, is actually the gross pathology of liver nowadays, and you have excellent techniques to identify any intrabiliary lesion fairly accurately and reasonably well. So this, I think, has taken away the punch out of many of the biopsies, especially in the neonatal age group, where there's often where there used to be a difficulty in identifying whether it's an extrahepatic obstruction or neonatal hepatitis. Even then, it's still many cases they still do biopsy, but it's actually not needed in many of. So when you see cholestasis, you can broadly classify whether it's hepatocellular or whether it is biliary, right? Hepatocellular, you can see in a whole lot of alcoholic, non-alcoholic diseases, infiltrative disorders, drug-induced, genetic, infiltration by malignant diseases, and other paraneoplastic conditions, toxic parenteral nutrition, and so on and so forth. And of course, viral hepatitis. Biliary, PBC, PSC, IgG4 associated cholangitis. Please remember, just because IgG4 is raised, it does not mean it is IgG4. We had an excellent example by which Dr. Ashim showed. And whenever you see a granuloma or an eosinophil, stay away from IgG4, whatever may be the levels. Okay, first exclude other things, only then you think of IgG4. Then, of course, secondary sclerosing cholangitis, infectious diseases, and so on. So now, if you see, you have excellent laboratory tools per se. For example, in primary biliary cirrhosis, the finding can allow you to suspect the disease, diagnose the disease, and even prognosticate by a variety of laboratory tests. You don't need to do repeated biopsies, but nevertheless, for fibrosis and other things, you definitely would like to do a liver biopsy. So in the findings of cholestasis can be similar in a wide variety of diseases. For example, if you take a post liver transplant situation, okay. So now if you take the post liver transplant situation, for example, whenever you see cholestasis, because other than mechanical obstruction to a biliary tree, which fairly well they can find out in most instances, when you see intrahepatic cholestasis, the histological features may be almost identical. Then you actually have to do a clinico-pathological correlation in most of the cases. Please remember, in most liver diseases, never can you diagnose in isolation, histology alone or clinical features and laboratory findings alone. It is invariably one supplements and complements each other. For example, in less than 6 months, it may be because of primary graft non-function that occurs more recently, ischemic or reperfusion injury, small for size graft, especially when it's not the entire liver that's being transplanted. Generally, the liver size should correspond to about 0.8 to 1% the entire body weight. If it is small, then of course you can get this phenomenon of intrahepatic cholestasis. Infections, of course, like CMV occurs much earlier than the others. Acute rejection, which is seen in quite a few cases. Antibody mediated rejection, and of course, drug induced liver disease. More than 6 months, it could be because of chronic rejection, infection, drug induced liver injury, and recurrence of the original disease. There would be features that will help you in identifying each one of them. But in many of them, there's so much of overlap that I have just put this to show you that you must have a good clinical pathological correlation. Like, for example, we often miss drug-induced liver disease. Now, what are the drugs that cause this? I just took this as an example. This was in 2017. They analyzed post-liver transplant cases with drug-induced liver injury, which is proven. All those with asterisks showed either cholestasis or cholestasis with hepatitis or a mixed pattern, right? So you see, this is the number of cases more than 50, 18 to 49 reported cases, 4 to 11, and very rare. Okay? These are the drugs that are frequently used, and these are the less frequently used. they also can cause this disease. And of course, these are rarely used drugs and they also cause this disease. Actually, if you see the list, it's almost the entire Goodman-Gilman. There's nothing that is left. So we often tend to underestimate the drug-induced liver disease or a component of drug-induced liver injury causing cholestasis in many of these cases. So it's not as easy as it seems, and there is no way to point out. But as was pointed out earlier, if you see centrizonal and portal injury with cholestasis and a lot of eosinophils, not 3 or 4 or here there lying eosinophils lying here, there it can be seen even in a rejection or any other disease that you can name. As Dr. Dhanpat Jain has rightly pointed out, when you see a lot of them, but it's not necessary that always you will find eosinophils associated with drug-induced liver injury. This is just to show you the complexity. Now, we have been talking about how good are the laboratory and clinical markers, and this was a study done long time ago with they took drug-induced liver injury because the cause was proven, and they found whether it's acute hepatitis, chronic hepatitis, whatever the predominant pattern, the green gives the cholestatic component, and the blue is the hepatocellular, and the red is the mixed component. And they just use a simple technique, ALT, ALP more than 5, anything above that was hepatocellular, ALT, ALP, anything below 2 is cholestatic, and the remaining is mixed. And to their surprise, they found a very good concordance. So you see, it's not necessary that always a liver biopsy will be done by the clinician. And in fact, even if it's done once, it's hardly ever done for follow-up. Now, having said that, the liver biliary tree can be differentiated into 3 domains, responding differently to biliary obstruction. So now if there's a biliary obstruction, there are 3 domains. Now the larger bile ducts predominantly respond with an increase in their diameters. So they accommodate more biliary fluids, and this is very well seen by imaging. Right? Then if you go upstream into the interlobular bile ducts, they undergo extensive remodeling. And so instead of showing few bile ducts, you get a mesh of bile ducts, what is called bile ductular proliferation. And the function of this bile ductular proliferation is that the inner surface, which is more corrugated, branching and rejoining, it allows more of the bile to be absorbed. In these ducts, it's not necessary that the diameter will be dilated. So the dilatation is seen in the larger ducts. Then more upstream is the canalicular network. In the canalicular network, once again, there are not much changes except that they dilate. So the dilatation is seen in the larger bile ducts and dilatation is seen mainly in the canalicular. Whereas in between, there is a proliferation of the bile duct. So this is the basic thing that we see. And in fact, in rodents as well as in humans, the bile salt and bilirubin concentration decrease because of cholestasis, because of these mechanisms. They tend to absorb as much bile salts and especially bilirubin into the circulation. So after a prolonged time, if you see the bile, it's no longer green in color. It becomes white in color. And in fact, many surgeons experience this and they say they have seen white bile coming out when they have made the resection. Okay. Now, what are the hepatocellular changes? There are 2 kinds of changes. One is because of the bile pigment, that is called bilirubinostasis, and the other is because of the bile salts, that is called cholate stasis. Bilirubin is not toxic to the hepatocytes, whereas the bile salts are toxic to the hepatocytes. So cholate stasis results in some of the changes which are in the seen in the cells, whereas bilirubinostasis results in the change which you see dilated canaliculi with green bile and so on. So what do you see in bilirubinostasis? Hepatocyte pigmentation, the cytoplasmic pigmentation, canalicular dilatation with inspissated bile. Then the pigment gets regurgitated in Kupffer cells. They also become pigmented. And you will find that because I told you the flow is from the centrizonal to the portal, naturally when there is an obstruction or anything, the the cholestasis is more often seen in the centrizonal area than in the periportal area. So there is a distribution of this bilirubinostasis from the centrizonal to the periportal. Hepatocellular degeneration, you find ballooning change, which with encrustation of bile and gives somewhat a foamy appearance. There's some fat also, or flocculent cytoplasm, which is called feathery degeneration. And of course, you have this typical ballooning degeneration. The sodium potassium pump is damaged, so it just bloats up full of water or hydropic change. Then you have changes in the cytoskeleton. You get Mallory-Denk bodies, which are more often seen in the periportal region than in the typical centrizonal region that is seen in alcoholic hepatitis. Then you have bile infarcts, which will come to later. Then you have accumulation of certain metals, which are whatever is excreted through the bile. For example, copper and copper associated protein. Once again, they're mainly in the periportal region, which is the site of maximum secretion and absorption. Okay, so that's why you see in the periportal region. Then you can get rosettes, which are not hepatocytic, that are actually called cholestatic rosettes, and sometimes you get coalescence of hepatocytes. So these are the changes which you see. So that you find in this. Now, when you come to the portal tract changes, it's same like inflammation. So you have edema. Edema is generally out of proportion to the inflammation. And that is how you can differentiate it from, say, what you get in hepatitis. You get a lot of inflammatory cells, hardly get any edema there. Whereas in the biliary lesions, you get a lot of edema. And you get an inflammation, mixed pattern of inflammation with a lot of neutrophils. Important that you identify neutrophils. Then you have bile ductular proliferation, dilatation of some of the larger bile ducts, segmental bile ducts. Then you can have neutrophilic infiltration into the bile duct epithelium. And you have then, of course, the end result of inflammation, which is fibrosis. The fibrosis results in expansion of the portal tracts. The fibrous septa, typically you have nodules that are of a jigsaw pattern, and we'll come to that later. So the bile salts results predominantly in the portal tract changes. The bile pigment results in both centrizonal as well as in the portal tract. Please remember, in histological sections, bile is not necessarily green. We have got so many slides which are of different hues. For example, it could be almost dark brown color. It's nothing but dark green. Sometimes it is yellowish. It all depends on how the pigment is oxidized to various components. And sometimes the pigment is removed and there's a mucoid component. It almost looks reddish. So this is also bile. It is nothing else. So you have something that looks red, yellow, and somewhat brownish, and of course you have the typical green bile. All these are part of cholestasis, right? Now here there is a linear core of liver tissue, and you look at this portal tract. Not much inflammation, and it looks pale. It's edematous. And look here, if you see carefully, it's somewhat green. We'll go into the higher magnification. and you'll find these green things in the canaliculi, which are dark green, and this indicates that there is canalicular cholestasis. There's nothing much to tell, and except that you find that the portal tract is edematous with inflammation. This is all because of the bile salts, part of the cholestasis, and that is an example of bilirubinostasis in the centrizonal area. And if you see carefully, of course, you may find changes in the hepatocytes, right? Now, this is another, please remember to examine all the fragments carefully, because it's not necessary that the cholestasis will be uniform, right? And look at this, this is also cholestasis, and with this you're finding this enlarged hepatocytes. Somewhat you could call it feathery, if it is more pale you could call it balloon, and you see the bile pigment could be within the cells or within the canaliculi, and of course even in the Kupffer cells. If you see carefully, you may find in some of them. Now, this is once again a portal tract showing edema with hardly any bilirubinostasis. So, it's not necessarily that all the changes will go hand in hand. This is another example to show you this. Now, if you see the hepatocytes, we have found that you'll find that most of the hepatocytes, they have a peculiar color that's more sometimes encrusted with green. They look slightly larger, and the cytoplasm is somewhat granular. This is seen in a lot of cholestatic diseases, sometimes in drug-induced, and that could be mainly because of the proliferation of some of the mitochondria. This is not necessarily finding that you can say is pathognomonic or anything. Then cholestasis is generally more in zone 3 than in zone 1, that is seen in this case, seen centrizonal area, right? And this is another example where you find biliary bile duct proliferation with edema and inflammation here, and with cholestasis mainly in the centrizonal areas, right? Now, if you in the periportal area, if you see, look for the hepatocellular changes adjacent to a edematous portal tract. Invariably, you will find the changes that have been described, that is the ballooning change with encrustation of bile in them. So this is not because of hepatitis, which is viral or any other reason. This is mainly because of the cholestasis, right? Whatever may be the reasons. Okay. And you will find apoptotic hepatocytes, which is another feature which is seen in pure cholestasis, right? And then you find neutrophilic infiltration, which is seen here and there. The other thing that you will find is bile infarcts. Now, these are areas of necrosis of hepatocytes with encrustation of bile pigment, which is called an infarct. These bile infarcts are seen more often in portal areas or periportal areas, and they are a manifestation of extrahepatic obstruction. Bile infarcts are also known as Charcot-Gumboldt necrosis, after those who described it many years ago, Jean Martin Charcot and Albert Gumboldt. And one important thing is, in contrast to other organs, infarcts are mainly ischemic in origin, or cell death because of ischemic causes. Bile infarcts are necrotic because of bile leakage. So the necrosis is because of the deleterious effects of the bile salts. So they become necrotic and the bile gets encrusted in them, and that's what you call bile infarct. The term infarct is there. On the other hand, bile lakes are within the portal tracts and they are huge amounts of extravasated bile, and they are also indicative of large bile duct obstruction. So infarcts and large and bile lakes are common manifestations of large bile duct obstruction. So why do you get bile infarcts? You get bile infarcts because it allows leakage from the overloaded biliary tract into the blood. Actually, from the necrotic cells, it goes into the sinusoids, and therefore, in a way, it protects the surrounding hepatocytes from bile salt toxicity. And in fact, in the chronic phase after bile duct ligation in rats, there is a reduced sinusoidal bile salt uptake. And the dominant protective feature then from the sinusoid shifts to the kidneys. And the kidneys contribute to the elimination of these bile salts. And this continues until there is a phase of polemic nephropathy. And that's almost end stage, you know. There's also, so you get a renal failure because of the bile salts also of long-standing cholestasis. So the protective mechanism, what is believed based on experimental studies, lasts for some time, and then the kidney takes over until there is polemic nephropathy. The other changes are in the Kupffer cells. If you do a diastase pass stain, they become prominent, and you'll also find this bile encrustation in them. The proliferation of bile ducts, if you see, they are irregular, and it's not necessarily that they will have a dilated canaliculi. The cells that you see can also include lymphocytes and plasma cells. So please see that if there is no portal tract changes, there must be a non-obstructive etiology in the larger bile ducts, and always examine for vanishing bile ducts. This is something that is often missed. And when do you call a vanishing bile duct? See, normal portal tracts will have about 5 to 8 profiles of these ducts on an average, if you count numerous portal tracts. So the ratio will be 0.5 to 0.8 normally, provided that they have an artery, because the artery and the bile duct develop together. If it is below 0.5, then of course you say the bile ducts are lost. So the portal tract changes in hepatocellular or non-obstructive cholestasis can be seen in paraneoplastic syndrome, in toxic shock syndrome, toxic condition, sustained sepsis, and severe hepatitis. In sustained sepsis, please look for changes in the canals of herring. Generally, you get inspission of bile in these canals of herring, and isolated, if you see them, they are almost always indicative of sepsis or what is called ICU jaundice in many cases. And this is typical of cholangitis lenta. I'll show you another slide. So here what you are seeing are these canalicular dilated with bile ducts and these changes in the hepatocyte. You'll notice that these changes are repetitive and they may be associated with fibrosis. Right? So these are the changes that we are seeing. This is a diastase pass because bile also contain mucoid material with them. They invariably stain with diastase pass. And please remember, whenever you see cholestasis and you do diastase pass, please don't mistake them for alpha-1 antitrypsin bodies or any other thing. Yeah? Now there are two kinds of rosettes. One is this hepatic rosettes, in which you don't see a canalicula in the center. This is typical of autoimmune hepatitis and hepatitis because of other causes. In cholestasis, you get cholestatic rosettes, and this contains a ring of hepatocytes with a canalicula and which may contain bile in them. you don't see a canaliculus, this is a hepatic rosette, which is typical of autoimmune hepatitis, right? So bile ductular proliferation and bile ductular reaction is seen not only in cholestasis but as a regenerative phenomenon. Here you see portal edema with bile ductular proliferation. This is seen mainly in large bile duct obstruction. Okay, so then you can get fibrosis. Then fibrosis, these are the reticulin fibers, and within them you may find these profiles of bile ducts. Right? So look for neutrophils which may infiltrate the bile duct epithelium as well as in the portal tracts. I will not go into the details. You may find some eosinophils and plasma cells, but neutrophilic infiltration of bile duct epithelium is important. Now, in the periportal area, sometimes you get this canals of Herring filled with inspissated bile. There may or may not be much of inflammation, but whenever you see this, please suggest sepsis in a clinical setting. This is what is called cholangitis lenta. In many biliary diseases, you find degeneration of the biliary epithelium by way of vacuolation and inflammation, predominantly neutrophils, right? So these are the other findings that you see. And even in obstruction, which may not be because of PSC, you may find a ring of fibrosis around the larger bile ducts. So this is fibrosis. In the early stages, you'll find few reticulin fibers, and later on the fibrous expansion occurs. These are the larger ducts with neutrophils. These all indicate the large bile duct obstruction, right? Now in PSC, of course, you will find the typical finding of onion skinning around the large bile duct. Please note, this you may see in biliary obstruction of long standing of whatever, of any reason whatsoever. Okay. Now you may find granulomas, then think of PBC. Now what is the type of fibrosis that you get in biliary obstruction? In biliary obstruction, you don't get round nodules. You get these nodules which are of jigsaw puzzle shape. And you'll find this, you see this is another example where, and invariably there will be some edema adjacent to these nodules if the obstruction is continuing. This you don't see in hepatitis. See this? These are the examples in the Masson's trichome. And if you see the reticulin fibers, you generally find parallel arrays just adjacent to the nodule. This is also another finding that helps you to tell that this is because of biliary obstruction. See here, these parallel arrays here of reticulin fibers. This is generally not seen in those which are typical of interphase hepatitis. So these are the two features that can help you decide. Then addition, you can find Mallory's hyaline and copper binding protein. So in chronic obstruction, you get fibrosis, lymphocytic infiltration, loss of interlobular duct, concentric onion skin fibrosis, Mallory's hyaline, and increased copper. So these are the features that you find in chronic biliary obstruction. You may get interface hepatitis, especially in PBC and some early cases of PSC. This is the biliary piecemeal necrosis, where you find these little bile ducts forming almost like interface hepatitis going into the nodule. This is the ductular piecemeal necrosis, which is similar to this, and fibrosing piecemeal necrosis. And this is the granuloma that you find in PBC, right? So, and this is a case of PSC in which you find this. Please note, in PSC, the gold standard is imaging, because, for example, if you get the small ducts that are affected, which are coming in your needle, then you get the typical features. If it is a distal duct that is affected, you get a large bile duct, you get a bile duct obstruction. If the other bile ducts are affected and you take a biopsy in which these bile ducts are flowing freely, the bile is flowing freely in this ductular system, you may not get any changes. So you get different types of changes in PSC. That is why imaging is the gold standard. Do you require CK19? Not in all cases. It's not required actually. But in some cases, it does help, right? So the defining features in active cholestasis, chronic cholestasis, ductal and ductular are mainly canalicular bile flux, periportal changes, bile pigment in interlobular ducts, and bile pigment in proliferated bronchial. You can get visible bile pigment in all except in chronic cholestasis where it's occasional. The primary location is centrilobular in active cholestasis. In the remaining, it is generally portal or periportal. In larger ones, they are generally confined to the portal tract in later stages. And of course, you can get other features like hepatocellular damage, and the clinical setting is active cholestatic conditions, including drug-induced, chronic cholestatic features which are periportal in chronic conditions, including PBC and PSC, and ductal cholestasis, of course, you get in large bile duct obstruction. The ductular, please always remember if there is cholestasis in the interface, the portal tract and the hepatocellular region, don't forget to mention sepsis in clinical setting. So large bile duct obstruction, small bile duct obstruction, and hepatocellular. The hepatocellular is seen in pure cholestasis, drug-induced injury, whereas small bile ducts, PBC, PSC, and large bile duct changes, of course, which are mechanical, like stone, tumors, and so on and so forth. Right? So now supposing this is a 4-year-old male with recurrent icterus for 6 years, pruritus, and you have serum bilirubin 2.8, direct predominant, ALT, AST, just borderline alkaline phosphatase, 14 total protein albumins. And this is the liver biopsy finding, right? This is the liver biopsy, okay? Looks as if there's some edema, but if you see here, just along the canaliculi, there is some pigment all around, especially in the, it's mainly in the centrizonal area away from the portal tract, right? This pigment is mainly in the canalicular pole, not in the sinusoidal pole. This the diastase sparse, and of course, this more brown. So how would you proceed further? This is a Fontana mason which brings out this pigment so clearly. So you see this is in the canalicular. So this is obvious. There is no marks for guessing what it is. It's a Dubin Johnson. So here you see there's no cholestasis at all, right? Then you see 3 weeks infant with persistent unconjugated hypobilirubinemia, and then you see, of course, these are the centrizonal area with large ballooned hepatocyte, not much of portal tract changes, and some giant cells which have 3 or more nuclei. Portal tract don't show severe changes, right? So this is a case of neonatal hepatitis. The wide variety of reasons why you can get. So this is a 4-month-old and a liver biopsy has formed. And look at these parallel arrays. Although the nodules are little rounded, see these parallel arrays which are typical of this. There is cholestasis, ductular as well as in here, right? And other features of cholestasis are there. You get apoptosis and dilated this hydropic change or in the hepatocytes, and of course there are a lot of extramedullary hemopoiesis. In addition, you are finding this parallel arrays of ducts which are here. See, so this is typical of a ductal plate malformation. This was a extrahepatic biliary atresia with a ductal plate malformation in the same patient. Okay, and this is the jigsaw puzzle like thing that you get in biliary disease, whereas in hepatic disease, the nodules are rounded. So this helps you. So this was a case of extrahepatic biliary atresia with ductal plate malformation. This is a 3-year-old girl with conjugated hyperbilirubinemia. He had cardiac and ocular malformations. And if you see, these are bland changes in the portal tract, some inflammation, and when we examine more, there's hardly any bile ducts. So there is intrahepatic paucity of bile ducts, right? This is another normal case to just show you how it is. So this is the case of paucity of intrahepatic bile ducts, and this diagnostic of paucity when it's less than 0.5, 0.8 to 0.5 is suspicious paucity. This was a case of syndromic Alagille syndrome. So cholestatic diseases can be associated with other syndromic disease. This is a 48-year-old male in hepatic coma, died after being admitted. We find a lot of Mallory's island, fatty change, and of course, bile pigment here. So it's encrusted there. So this was a case of alcoholic hepatitis with cholestasis, who died in the casualty. I'm not going into the detail. So you see, there are other systemic diseases also that can have these changes. So with this, I'll stop here. Took a long time. Thank you very much for this. If there are any questions, anything.
Thank you, Siddharth, for a very lucid talk and showing us the algorithm to approach to a liver biopsy, which shows cholestasis. So I think there are few questions which I would first read out for you. If Siddharth,
Yeah.
can you see this
I
question?
If there are any comments, Ashim and
Yes,
this
yes,
one,
we'll ask for comments, but there
Anpat
are
and
some
Sanjay.
questions like somebody has mentioned that Mason trichrome stain shows apposition of portal tracts and central vein depicting parenchymal loss. Do we still need reticulin? That is one.
Okay. Do we still need
Reticulin stain or
reticulin
not?
stain? No, you see, actually, in all liver biopsies, no, we, I think the others also can tell, we do certain mandatory stains. They are not special stains, they are the usual stains. That includes usually a diastase pass or a reticulin, and a Mason's trichrome is done in all our cases.
Yes.
So now
there is a okay.
and we find that instead of Mason's trichrome, to find out collapse, it is better to do a reticulin stain. And even if you are doubtful, then you do an elastic or an Orsin stain. Mason's trichrome generally, if it is fibrosis, no, it is deep blue in color, and that requires some amount of you have to be used to the counter stain malachite green or the light green or whatever aniline blue that they give, and you have to be used to it that this dark color is fibrosis and this light color is because of collapse or whatever it is. So Mason's trichrome, if you want to use it for differentiating collapse versus fibrosis, where the centrizonal areas near the opposed to the portal tract, I wouldn't say it is a very good stain. It's better to do a reticulin or Orsin stain. I do not know, Ashim, what is your opinion?
Yes, you are absolutely right. Reticulin stain will better appreciate this collapse rather than a Mason's trichrome. I think that is a standard protocol everybody follows.
There is a question from one of our DM student, Dr. Nishta, and she has asked, sir, sometimes we only get rarefaction of hepatocytes, which on PS stain also is pale, PS positive. Do you consider that as an intrahepatocytic cholestasis? So that is one, and the second question again she has asked is, Also, do you believe that during processing there is some part of the bile which gets washed out?
Yeah, see, some part of the bile may get washed off because, but you see, it's not necessary that bile is just remaining like that, you know. Bile is generally, the bile pigments are, some of the pigments may get washed out, but it is generally associated with other compounds. There is some mucoproteins and other things which are associated with it. Therefore, not everything gets washed off, right? So it's theoretical. Now, see, the just rarefaction of the portal tract may indicate edema, but portal tract edema alone will not make a diagnosis of cholestasis. In pathology, we know, no, one swallow doesn't make a summer. Usually, there are 2 or 3 things that 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 have to be associated so that you make a diagnosis, and never it is based on a single feature. Of course, a rarefied PS staining may indicate there's some edema, but if there's no bile duct proliferation, there's no cholestasis anywhere, it could just be a form of bland fibrosis, which I think one of Dr. Das's case, no, in which there was cryptococcus. If you see one of the diastase pass stain, the cryptococcus was stained very brightly. On the other hand, that fibrosis part was hardly ever stained. So you see, there could be other reasons for this.
There is a question from Dr. Sunaina Mishra, who used to be our student here, and she had a thesis with Dr. Das itself. She is asking, there is one.
I think this one, no, Dr. Das, he did a wonderful thesis of one of his students. I happen to have seen that, and he published that in Histopathology. Consequently,
Anshul
Das,
was
Yes, sure, was see.
and she couldn't join us. We had sent her a request, but she couldn't join us. So
yes,
this,
Ashim, would you like to elaborate on that?
yes, this is another one who is working in Delhi now. So when do you suspect ductal plate malformation in biliary atresia?
Can I take this?
Yeah, please.
Yeah, sure.
You suspect bile duct malformation in a biliary atresia when you see unusual fibrosis, even at the age when Kasai operation is done, like 60 days. Second thing is that you have to see a central part of the portal tract, which will show mainly the abnormal shaped bile duct in a very myxoid connective tissue. And it is all important to assess this small part in the center of the portal tract, but the periphery of the portal tract will show features of a biliary atresia like ductular proliferation, significant inflammation, and other things. So whenever you see something different in the central part of the portal tract, you should suspect an unusual fibrosis. Even at the age of 60 days, when Kasai is done, you should suspect ductal plate malformation.
Yeah, that's the center part. Yeah, I would like to tell another thing, in biliary atresia, please remember that the fibrosis sets in very, very rapidly. If you don't do something within 12 weeks, it might be quite late. And the other thing is that biliary fibrosis is one fibrosis in which if you act early, it is almost reversible. So these are the 2 things that I forgot to mention.
So I think we can, there is one comment made by Dr. Bush, which I'll read. And he said that in the differential diagnosis, we could add congenital hepatic fibrosis, dilated bile ducts in excess numbers with varying degree of fibrosis of the portal tracts, no cholestasis in the lobules, fibrosis also like zigzag.
Yeah.
That is true.
Okay. So
Agreed, 100%.
Can I request Dr. Dhanapal to make any comments after this presentation?
All I can say is that thank you, Siddharth. Again, a wonderful lecture.
whenever you give a talk, I always learn something new, and it was the same case again. I picked up a couple of things which are new. It is your masterful way of delivering a talk that not only you highlight so many histologic findings, but you always give good explanations why you see so. So, thank you. I mean, really nothing to add to your lecture, but it was, so good to hear you again.
Dhanpat, you are very modest.
Yes, he always is. Anyway, Sanjay, shall I? Do you want to have it?
Yes, yes.
Then
Once again, thank you for an excellent lecture, going over some basic concepts. Like Dhanpat said, we sometimes, overlook these basics, and we're talking about advanced things, but it's very helpful to know why we are seeing what we are seeing. So thank you for a very nice session.
thank you, Siddharth, so much for your participation and agreeing to participate in the CME. It was very kind of you.
No, anything. How can I refuse, Ashim? And you, or anybody from PGI, in fact.
No, you have been a very good friend, and we always, you are easily approachable also to us, and I think that's why we take this liberty. So, okay, so now I think in the interest of time, now we go to the next deliberation, which is by Dr. Sanjay Kakkad. When we were planning this CME, he happened to be in Chandigarh, and Sanjay is always visiting the department, and we requested him, he agreed. And I think most of us know him very well, but it's customary. I had sent him a template. Please fill in this for your introduction. You see how humble he is, and how modest, and how gratifying it is for PGI Pathology Group. In honors and awards, he mentions PGI Pathology resident and senior resident. You see, we are overwhelmed, and I have always thought, and my colleagues do feel that he is one of the bright stars we have. And the other one is also sitting here, Dr. Dhanpat Jain. So these are the two people who have made us proud by achieving so much in their lives, in their careers. But briefly, I would introduce Sanjay. Sanjay is a professor of anatomic pathology and chief gastrointestinal hepatobiliary pathology service at the School of Medicine, University of California, San Francisco. He's also the director of GI services, GI fellowship program at the same university. As I said, the Sanjay comes to Chandigarh means he's a local fellow, and he has studied schooling, etc. at Chandigarh. Then he went on to CMC Ludhiana for his graduation. After that, he joined PGIMER Chandigarh. He's finished his residency, that is MD Pathology, and which he finished in 1994. Then he joined as a senior resident, but in 96 he moved to USA, and he joined the University of Illinois at Chicago. Then moved on to Mayo Clinic Rochester, and did fellowship in GI liver pathology and fellowship in molecular pathology. And following that, I think he moved to University of California, San Francisco, and where he started as assistant professor, then associate professor, and became a professor from 2011 till now. He also serves as a staff pathologist at the VA Medical Center. VA is Veterans Affairs Medical Center at San Francisco. So, Sanjay is a very accomplished person, and he is a member of very highly regarded societies. I think I can't name everything, but something like most people here understand is College of American Pathologists, USCAP, that is United States and Canadian Academy of Pathology, United States Gastrointestinal Pathology Society, then American Association of Study of Liver Diseases, etc., etc. More than that, I think Sanjay has been a member, vice chair, chair of many of these committees of these professional organizations. So, as far as publication is concerned, he has published extensively. I can just say that I was going through his CV. has more than 136 publications. Of course, they are in highly reputed journals, but books and chapters, etc., more than 36. And I was going through what are these books. You know, these books, WHO classification of the tumors of digestive system, 2019, and 4 chapters in 2020 have come up in reference books such as Maxwell textbook on liver pathology, AFIP fascicles, and surgical pathology of GI tract, liver, and pancreas. So I don't know, this is prolific writer, and he is a very popular teacher. He, I think, mentors students. He has taken up directorship fellowship, and he's a fellowship director since 2015 at this university, and has been mentoring residents and guiding them for their research projects, etc. On the research front, I found that he has so many grants, etc., etc. So, man who I think is working most of the time as far as I can think. But I know that he has other interests also, like sports, philosophy, modern art, chess, mythology, historical places, etc. So he is a versatile man, and he comes to Chandigarh quite frequently to visit his parents, and he is very popular in PGI Chandigarh. Whenever he comes, we request him to deliver lectures, and he kindly agrees. So today you are going to listen to him. His title of the talk is Next Generation Diagnosis: Role of Genomic Analysis in Liver Tumors. Sanjay, over to you.
Thank you all. Good evening, everyone. Thank you, Dr. Radotra. You are always, very, very generous. And thank you for inviting me to be part of this session. It's such a great privilege to be part of this, CME event, which is honoring Dr. Das. And he's been my teacher from my junior residency, foundational days at PGI. I've been visiting PGI at least twice a year, sometimes even more than that. So it almost, to me, feels like I never really left. So today what I'm going to focus on is, sorry, my screen is stuck right now. Okay. So today I'm going to focus on some of the limitations that we face in the diagnosis of hepatocellular tumors with the morphology and immunohistochemistry, and how some of the molecular tools can help in solving these diagnostic problems. I'll give you some examples both for hepatocellular carcinoma as well as for intrahepatic cholangiocarcinoma. Let's start with the question which we face often in liver biopsies, and that is the distinction of hepatocellular carcinoma from intrahepatic cholangiocarcinoma. Just a quick review of why is this distinction so important. This distinction is important because it has direct impact on management. So if the tumor is resectable, then in cholangiocarcinoma, in vast majority of cases, lymph node dissection is a standard part of the procedure, because cholangiocarcinoma metastasizes the lymph nodes in nearly half of the cases at presentation. While in HCC, this is in less than 5% of cases. So usually it is not a standard part of the surgery to do a lymph node dissection with the resection of HCC. Now, if the tumor is unresectable or if chemotherapy is being planned, then for cholangiocarcinoma, the standard of care is to use gemcitabine or 5-FU-based regimens. While these treatments do not work in HCC. And if the patient is being considered for transplant, HCC cases can be transplanted depending on what criteria are being followed, while in most of the centers, in cholangiocarcinoma settings, the patient will be denied a transplant. Now, that paradigm may be changing somewhat, and there have been increasing literature on how cholangiocarcinomas, especially smaller ones, can be transplanted with outcomes which are similar to HCC, but at present, a vast majority of transplant centers will not do a liver transplant for patients for cholangiocarcinoma. So you can see that this distinction has really important clinical implications. And we know that there can be morphologic overlap between HCC and cholangiocarcinoma. So here's an example demonstrating that. So this is a liver biopsy from a tumor. You can see a small amount of non-neoplastic liver here at the periphery. But the tumor cells are composed of these nests of polygonal cells, somewhat haploid in appearance. You have a prominent fibrous stroma in some part of the tumor. And the tumor cells are arranged in sort of nests or even tubercular arrangement in some areas. But the immunohistochemical profile did not yield a definite answer in this case. All the hepatocellular markers were negative, and even CK7 and 19 were not diffusely positive in this case. This is albumin in situ hybridization in this particular case. And since albumin is synthesized in the liver, it is a very valuable stain to demonstrate that this is a likely liver primary. So you can see the normal liver here, non-neoplastic, strongly positive, and the tumor cells also show patchy, strong stain. So this was a liver primary, but a confident distinction or a confident diagnosis of HCC or cholangiocarcinoma could not be made because of the overlap of findings in the case. Let me show you a few more examples of how morphologic overlap can exist. This is a typical adenocarcinoma in the liver. It's a intrahepatic cholangiocarcinoma, gland-forming, abundant fibrous stroma, and this was how most of the tumor looked like. But if you go towards the periphery of the tumor, this is where it interfaces with the adjacent liver. You suddenly see that the glandular architecture has transformed into a more tubercular and nested architecture, and it starts to look like HCC. And this is quite a common phenomenon in cholangiocarcinomas, that the periphery often has a more kind of solid or tubercular architecture. And if the biopsy is predominantly from this area or includes this area, then it can lead to an erroneous impression that you're dealing with either an HCC or a combined HCC cholangiocarcinoma. In a vast majority of the cases, the immunohistochemistry can help in that setting. This is a Hepar stain from this area, and you can see that the tumor cells are clearly negative for Hepar1. Another example showing you overlap of morphology. This is another case of intrahepatic cholangiocarcinoma with obvious glandular differentiation. But if you focus on this area here in the middle, it shows cells, tumor cells, which have more abundant eosinophilic cytoplasm and have somewhat a hepatoid appearance. This can, on morphology, raise the possibility that we are dealing with a combined HCC cholangiocarcinoma. But all the hepatocellular markers were negative in this area. And this tumor showed IDH1 mutation, which is highly characteristic of cholangiocarcinomas. And it's been well described that in IDH1 mutated cholangiocarcinomas, you can have areas which have a hepatoid-like appearance. It's not only the morphology, you can have immunohistochemical overlap, which also adds another layer to the difficulty in diagnosis. So these are some of the commonly used hepatocellular markers. In the case of arginase 1, which I found to be very useful because of its high sensitivity and specificity, and the cholangiocarcinomas are very rarely positive for arginase 1. But in my conversations with a lot of liver pathologists in India, and especially with Dr. Das, I've had many conversations, and he's told me that somehow arginase 1 doesn't work very well in India, and the sensitivity is much lower. And we haven't still figured out why that is the case. Even Hepar can be positive in intrahepatic cholangiocarcinoma in a small number of cases, but it's good to keep in mind that that's possible. Similarly, Glypican-3, 5 to 6% of cholangiocarcinomas can be positive. It's been my experience in some literature, you can get numbers up to 10 or 15%. And then we all know that CK7 and CK19 can be positive in a subset of HCC. So you can have both morphologic and immunohistochemical overlap in HCC and cholangiocarcinoma. And in some cases, the diagnosis may be difficult to establish based on these two parameters alone. Here's an example showing you a cholangiocarcinoma. There was no problem in the diagnosis. It's clearly gland-forming tumor. But I just wanted to illustrate that you can get arginase staining. This is perhaps the best arginase arginase positivity I have seen in a cholangiocarcinoma. Here's found a summary of the challenging situations that we face. In terms of morphology, if the tumor has a somewhat hepatoid appearance, but shows some unusual features like abundant stroma or a glandular or pseudogland-like, prominent pseudoglandular appearance, those can be problematic situations. In other settings, the tumor may not be very clearly hepatoid, but has a mix of trabecular, solid pseudoglandular patterns. And then there are tumors which are just so poorly differentiated that you really can't tell whether it is HCC or cholangiocarcinoma. And in these settings, if you have indeterminate immunohistochemistry, hepatocellular markers either negative or not convincingly positive, CK7-19 are the only things that are positive without gland formation or mucin. And if glypican-3 is the only marker, glypican-3 we know is an oncofetal antigen, and it is not a reliable hepatocellular marker per se. It is the most commonly expressed in HCC, but there's a wide variety of tumors that can be glypican-3 positive. So let me illustrate the value of genomic findings with this case. This was a biopsy from a 3 centimeter liver mass in cirrhotic liver. Here you can see these sheets of pleomorphic tumor cells in the background of a fibrous stroma. Here's another view showing you a prominent fibrous stroma and these nests, irregular groups of tumor cells. These are some benign ductules, not clear-cut cone. There was no definite glandular differentiation that you can imagine lumen-like structures here, but it was not very distinct gland formation. There was no mucin in this case. And here's the immunohistochemistry. All the hepatocellular markers, hepa, arginase, were all negative. Glypican-3 was negative. And CK19 showed strong staining in the tumor. So the question is, with this kind of morphology, all negative hepatocellular markers in the setting of cirrhosis, which statistically favors HCC, is CK19 just enough to diagnose cholangiocarcinoma in the absence of a distinctive gland formation or mucin? So given the important therapeutic implications of this diagnosis, we did do genomic analysis, and this can be very helpful if the characteristic mutational profile of either HCC or cholangiocarcinoma can be identified. So in HCC, the typical mutations, the most common ones, are the beta-catenin and the TERT promoter mutation, which is seen in nearly half of the cases. On the other hand, intrahepatic cholangiocarcinomas have very characteristic mutations, which involve IDH, BAP1. They can have fusions of FGFR2. So they have a very, very typical mutational profile. And in many of these cases, you can make a distinction of HCC, or at least favor HCC or intrahepatic cholangiocarcinoma based on this profile. So in the case that I showed you, the sequencing showed a TERT promoter mutation, which strongly pointed towards HCC. Even though the hepatocellular markers were negative, the morphology was somewhat hepatoid. And along with the TERT promoter mutation, it helped in the diagnosis of. So here maybe we have a lot of clinical colleagues in the session today. So maybe I can take a brief pause and ask them, what would be the approach to management in these poorly differentiated carcinomas if HCC or cholangiocarcinoma cannot be clearly diagnosed based on the biopsy. Imaging findings are also indeterminate. Any comments from any of the clinical colleagues who are in the?
Hi, Sanjay.
Oh, hello. Hi, Jay.
Yeah, very nice to see you. Yeah. So I think the question you are asking is the differentiation between the cholangio-CA and the HCC, if the radiology is also, kind of inconclusive, right? Is that the question?
Yeah. I'm just curious how you would manage such cases where it's inconclusive.
Yeah. So obviously, I mean, we do look at, before we go into the histology, would be the tumor markers, alpha fetoprotein, and now advanced cases, the PIVCA2 or the DCP, I think really helps us for HCC. On the other hand, CA 19-9 towards cholangio-CA, but sometimes the problem is you could have a combination, which you just said, the hepatocholangio, and both actually could be elevated, and again, you are in trouble. So in that scenario, I think we just rely on, if one imaging is not helping you, we go to the second imaging. CT has been done, we go to MR. And if that is also not helping, then final answer, obviously, we look at the histology only. But if the histology is not helping you, we look at other few things. For example, HCC almost always will occur on a cirrhotic background. It's a more vascular tumors. If you have associated portal vein thrombosis, I think goes in favor of HCC. Any positive viral marker goes in favor of HCC. Though all these things can happen in cholangio also, but I'm telling you the relative things. So then we take a clean, and the biliary obstruction goes in favor of cholangio-CA. Absence of biliary obstruction goes in favor of HCC. This is how we, try to do it. And if it's an advanced case, and then we take a call whether to do a loco-regional treatment or whatever we decide here.
Yeah.
Can I make a comment, Dr.
Yeah,
Sanjay? Yeah. So I also partly agree with what Dr. Ajay said, that radiology I would think is very important in this context, at least. I really don't know whether there are studies which have determined the sensitivity and specificity of imaging in this context, but we, at least since we do a lot of FNAC, we of course give them a lot of importance in this context. So merely having one gene or riding on one gene, would you put all your money that this is a case of HCC? There could be that one odd cholangiocarcinoma where the HTERT may have, that's why my question was simply on the basis of a single genetic mutation, would everything change? That is my question to you. And the second question is also, in such cases, would, more than genetics, would transcriptomics actually help when you're looking at lines of differentiation towards the hepatocytic versus the the cholangiocytic differentiation?
That's a very important point, that this is just another tool. So you have to interpret the results in the overall context of the case, including the clinical context, the morphology, the immunohistochemical profile, and molecular diagnosis is not anything magical which will just trump everything else. And like in this case, the TERT promoter mutation very strongly points towards diagnosis of HCC because there's a setting of cirrhosis. The morphology looked like HCC, but the hepatocellular markers were not very convincingly positive. And as you pointed out, you can have overlap of the genetic findings, just like you can get overlap of radiology, morphology, and immunohistochemistry. So there are well-documented cases of cholangiocarcinoma which can have TERT promoter mutation. It is rare, but it's well documented. And similarly, in hepatocellular carcinomas, you can have characteristic mutations of cholangiocarcinoma like IDH1. And if you see the TCGA profile data, they had 4 cases of HCC which had IDH1 mutation. And I saw a case of well-differentiated HCC in which the sequencing was being done for a research project, and that showed an IDH1 mutation. So it's absolutely true that the molecular tool is just another layer of diagnosis, but it's not in itself a final diagnosis. Any other comments? So the molecular profiling has also been tied to specific histologic subtypes of HCC. So here are some of the common subtypes that have been listed in the WHO classification, but none of these subtypes really dictate clinical management at this time, except for perhaps the last one. I'm just going to focus a little bit on the fibrolamellar hepatocellular carcinoma. So in many textbooks or literature, older literature especially, it has been stated that the outcome of fibrolamellar carcinoma is better than hepatocellular carcinoma. But if you carefully look at the outcomes of fibrolamellar and HCC arising in non-cirrhotic liver, it becomes clear that they are very similar. It's the cirrhosis which makes HCC prognosis worse as a group compared to fibrolamellar, but otherwise their outcomes are very similar in non-cirrhotic liver. But there are two important clinical considerations why the fibrolamellar carcinoma diagnosis can have a clinical impact. And number one is that it can affect the surgical approach. So if the diagnosis is being made on biopsy, and the reason is that fibrolamellar carcinomas have much higher propensity for lymph node metastasis compared to conventional HCC. And in some series, it approaches almost like 50% or so, which is very similar to cholangiocarcinoma. And the second is that it can affect enrollment in clinical trials. A lot of the clinical trials are focusing on conventional HCC, and they do not want to take other subtypes like fibrolamellar, which can kind of dilute the trial in a way. So it can be important for clinical purposes to make a distinction between fibrolamellar and conventional HCC. On most cases, this diagnosis can be made on morphology. So here is a characteristic fibrolamellar carcinoma demonstrating the triad of microscopic features. You have this abundant granular cytoplasm along with the prominent nucleoli, margination of the chromatin, and this lamellar pattern of fibrosis. All these three together are very characteristic of fibrolamellar carcinoma. It has been advocated that CD68, which is a histocytic marker, and CK7 should be done in fibrolamellar cases, and they are positive in nearly all of them. I personally have not done them for the diagnosis, but that's one of the recommendations that's out there, that you should do them in all cases. And if they are negative, then you should rethink about the diagnosis. If it's positive, it doesn't really make the diagnosis of fibrolamellar, but all of the fibrolamellars are positive for both these markers. One of the most exciting discoveries in the field of HCC has been this demonstration of this abnormality, this deletion of 400 kb in chromosome 19, which leads to the fusion of protein kinase A and the DNA JB1, which is a heat shock protein. And this fusion leads to this chimeric protein, which is thought to be the underlying pathogenic factor in carcinogenesis of fibrolamellar carcinoma. Now, this fusion is seen in nearly all the cases of fibrolamellar carcinomas, and it has not been observed in other tumor types in the liver, at least those which commonly enter the differential diagnosis of HCC. So it's been described in some oncocytic introductory tumors, but not in HCCs or cholangiocarcinomas, conventional cholangiocarcinomas, which can be mistaken for. Now, here's a case that I wanted to show you, which I saw earlier this year. This was a large tumor in a young patient, and in some places it had this oncocytic kind of morphology, which was reminiscent of fibrolamellar carcinoma. In other places, it had more of this sort of vacuolated, foamy kind of cytoplasm, which was not very typical. But you can get all these secondary cytoplasmic changes in fibrolamellar carcinomas as well. Now, there was no lamellar fibrosis in this case, but it was a biopsy, so it's possible that there was lamellar fibrosis elsewhere in the tumor. CK7 and CD68 had been done in this case, and CK7 was positive, but CD68 was negative here. So since the lamellar fibrosis was not there, CD68 was negative, and so at least some areas did not have a clear-cut fibrolamellar-like appearance. And the surgeon really wanted to know whether this was a fibrolamellar or not. So we did further analyze this case, and it was demonstrated that this fusion is present, which confirmed the diagnosis of fibrolamellar carcinoma. And as I mentioned, that in vast majority of the cases, this diagnosis can be made just based on morphology, and molecular confirmation can be done if necessary in a small number of cases which have more borderline morphology. This can also be demonstrated by break apart fish So the probes are available for the 5' and the 3' end of the protein kinase A gene. And since the split occurs in this gene, in this for the fusion to occur, what you see is a normal signal when both the probes are close together, and then the abnormal signal is when the 5' end is the 5' end is lost, so you only see the 3' ends. That can also demonstrate this fusion for fibrolamellar carcinomas. If you look at the WHO 19 classification, there are some well-defined entities: HCC, cholangiocarcinoma, combined HCC cholangiocarcinomas. But then there are these less well-defined entities, such as intermediate cell carcinomas and undifferentiated carcinomas. The diagnostic criteria for these are somewhat not that well-defined. Plus, these diagnoses really don't help in clinical management of the case. Let's take a look at entities. The intermediate cell carcinoma, by WHO definition, is that it is composed almost entirely of intermediate cells, and these are defined as monotonous cells with scant cytoplasm, typically in an abundant fibrous stroma. And the morphologic features are supposed to be intermediate between hepatocytes and cholangiocytes. The very definition is somewhat subjective because it's hard to say what is intermediate size between hepatocytes and cholangiocytes. That's a very, very subjective definition. And that is part of the problem for the definition of this entity. And if you see the literature on this entity, the different publications have used different criteria for diagnosis. In many of these studies, arginase was not used. And in many of them, HEPAR is actually positive in these tumors. And in one study, nearly 70% of tumors were even arginase. So from the descriptions and some of the images, a lot of these really look like that they could be a serous variant of HCC, which by definition has abundant fibrous stroma. There can be variations of opinion of what intermediate cell carcinoma is and what its morphology or immunohistochemical profile should look like. But at least in my own practice, if I see a tumor which has somewhat hepatoid morphology, even though it may be somewhat intermediate in size, as long as it is showing convincing positivity for hepatocellular markers, especially arginase 1, then I would be comfortable calling it serous HCC, even if CK7 or CK19 are positive. This is perhaps an example of what can be called as an intermediate cell carcinoma. What you see here are uniform nests of cells in a fibrous stroma, so somewhat trabecular arrangement in some places, and a very uniform monotonous appearance. But if you really look at this tumor closely, you will find areas like these ones where the cells have more abundant cytoplasm than others. And these have more hepatoid-like appearance, while these ones which are more uniform and have less cytoplasm are somewhat more indeterminate in terms of morphology. And here's an arginase stain which highlighted all those cells which had more abundant cytoplasm, clearly demonstrating that there is hepatocellular differentiation. And then all the other smaller sized cells were negative. So this is a HCC, and you can say that this has a prominent intermediate cell component. And if it was exclusively composed of these smaller sized tumor cells, which are negative for the hepatocellular markers, I think that would probably be a better definition for intermediate cell carcinoma than calling tumors which are clearly HEPAR or arginase positive as intermediate cell carcinoma. Let me show you this case and see how genomic analysis may help. This was a 54-year-old with chronic hepatitis C, no cirrhosis, and this was a 5-centimeter liver mass that was. This is a low par view. You can see predominantly the sheets of these tumor cells, some fibrous stroma. Closer look here, demonstrating that these tumor cells have abundant cytoplasm. They have sort of moderate nuclear polymorphism. Some of the nucleoli are quite prominent. there are some vacuoles, and you can imagine maybe some tubular-like structures that is distinct gland formation or not. That can be debatable. You can have HCCs with this pseudo gland-like appearance. So the glands were not distinct, and there was no mucin tumor. Here's the immunohistochemical profile. HEPAR was positive in the tumor cells. Other hepatocellular markers were negative, and CK19 also showed strong staining in the tumor cells. So whether this is an example of intermediate carcinoma or not, I leave it to your imagination whether this degree of pleomorphism should be allowed in intermediate carcinomas, and whether it fits the profile that has been described. I think what's more important is that this is clearly a tumor which is showing both morphologic and somewhat immunohistochemical overlap between HCC and cholangiocarcinoma. And I had this picture poster at the USCAP meeting, and a lot of pathologists came by, including a lot of liver pathologists, and I asked them, what do you think of the diagnosis? And I can tell you it was just a split answer, because I forced them, you have to choose either HCC or cholangiocarcinoma, and I really got a split of answers in this case. And the genomic analysis was done in this case. It did show IDH1 mutation, which favored a intrahepatic cholangiocarcinoma. I'm just telling you one or two results from the genomic findings. There were a lot of other findings in all these cases as well, but I'm just highlighting the ones that were the most important in the diagnosis. Okay, let's also look at another case which is has this very undifferentiated appearance. This was a 7-centimeter tumor in non-cirrhotic liver, and you can see these sheets of pleomorphic cells. They have no definite hepatocellular or glandular differentiation, and they would probably fit the definition of undifferentiated carcinoma, as has been mentioned in the WHO classification. It was positive for CK19, all hepatocellular markers were negative, and it also did not show any squamous or endocrine differentiation. So once again, we are at a point where the morphology and immunohistochemistry do not clearly provide an answer in this case. And here's the mutational profile of this tumor, which showed a P53 mutation and a BRCA1 mutation. So here's an example where the profile is not typical of either HCC or cholangiocarcinoma. And it also illustrates that we're not going to find definite answers based on genomic findings in every case. The BRCA1 mutation can be seen in around 5% of cholangiocarcinomas and is somewhat rare in HCC. So based on this, the oncologists decided to treat this as an intrahepatic cholangiocarcinoma. The overall findings, I don't remember the imaging in this case, but the overall findings were indeterminate after all the workup that was done. So let's shift focus on the second portion on how intrahepatic cholangiocarcinomas can be better identified using some of these tools. So if you see the WHO classification of cholangiocarcinomas, they have introduced a small duct type and a large duct type of intrahepatic cholangiocarcinoma, and these have a variety of clinical pathologic differences. And the mutational profile also tends to be quite distinct because the typical mutations that are described in cholangiocarcinomas, like the IDH mutations, the FGFR2 fusions, are more typical of the small duct type, while the large duct type tends to resemble the pancreatic adenocarcinomas, more frequent KRAS mutations. At this point, there is no difference really in management based on whether it's a small duct type or a large duct type. So I'm just not going to go further into detail on these two subtypes. But let's look at this case where the genomic profile was very helpful confirming the diagnosis. So this is a 2.5 centimeter lesion which was in cirrhotic liver, and there were some additional smaller lesions also observed on imaging. So this is a low power picture, and you can see that there is a glandular proliferation. It's sort of crowded in this area. Here it's sort of separated by fibrostroma. Here is the adjacent liver. Tumor appears to be kind of circumscribed, or this proliferation rather appears to be circumscribed compared to the adjacent liver. Here's a closer view showing you very well-differentiated appearance, very minimal cytologic atypia in these this glandular proliferation. There were some architectural abnormalities. You can see crowding and almost fusion of these. This area, on low part, was quite a crowded appearance. It was very concerning. The cytologic atypia was mild, but the architecture was very concerning. Angiocarcinoma. But given the gravity of the diagnosis, the implications, further workup was sought. Just to mention that in bile duct adenomas, which can sometimes be difficult to distinguish from cholangiocarcinomas, the mutations that have been very well described are those in BRAF. Depending on the study, anywhere between 50 to almost 90% of cases will show BRAF mutation. And here's an immunohistochemistry, which is the antibody specific for this BRAF V600E mutation. And this is a bile duct adenoma, which you can see is positive for BRAF. But this was not the case that I showed you. The case that I showed you is this one, which showed a loss of ARID1A by immunohistochemistry. You can see the internal control here, and the neoplastic cells are negative. So loss of ARID1, which is ARID1 is a chromatin modifier gene, and loss of ARID1, it's not been very widely studied in benign versus malignant biliary lesions, but loss of ARID1 would be highly unusual in a benign process. And the genomic analysis also confirmed the presence of ARID1A mutation, and it also showed multiple copy number changes. There were multiple log gains and losses across many chromosomes, which was very unusual again for a benign process. Yeah, even though it was a very well-differentiated case with very minimal atypia, the combination of the architectural abnormalities that were seen on the biopsy, along with these genomic findings, have to further confirm that this was an intrahepatic cholangiocarcinoma. Now, we can also exploit the mutational profile of intrahepatic cholangiocarcinoma to distinguish it from metastatic adenocarcinoma in selected cases. Now, we know that this is a common problem faced in liver biopsy, that you cannot distinguish other adenocarcinomas morphologically or even immunohistochemically from intrahepatic cholangiocarcinoma, especially like from pancreas or gastric adenocarcinoma metastasis. But as shown here, some of the mutations that you observe in intrahepatic cholangiocarcinoma, IDH1, the BAF1 mutations, FGFR2 fusions. So these are each observed, depending on the study, between 10 to 30% of cholangiocarcinoma have them. But these are very rare in some of the other adenocarcinomas, which are commonly seen in the liver and which can be confused with intrahepatic cholangiocarcinoma, especially if you see pancreatic and esophagogastric numbers, especially like for IDH1, are very low. So if you see that, then it's very likely that you're dealing with an intrahepatic cholangiocarcinoma rather than metastatic tumor. There's an illustration of a case where this was really helpful. This is a 58-year-old who had a history of a grade 2 neuroendocrine tumor of the pancreas. And on follow-up, there was a liver mass that was observed, and this is a biopsy from the liver mass. And here you can see that there are these tumor cells and these irregular clusters in of fibrous stroma. And the morphology, on first glance, really doesn't look like neuroendocrine pleomorphism. The overall uniform appearance of a well-differentiated neuroendocrine tumor is not present in this case. So the immunohistochemical profile showed that the tumor was mucin negative, chromogranin was negative, but synaptophysin showed kind of weak to moderate staining in the tumor cells. And given the history of pancreatic neuroendocrine tumor, the possibility of metastatic, well-differentiated neuroendocrine tumor with relatively unusual morphology was always had to be entertained. So here's the immunohistochemical stain for BAP1, which shows a loss of BAP1 in the tumor cells. See the stromal cells positive in control. And the sequencing also confirmed the presence of BAP1 mutation. So BAP1 is one of the mutations that is commonly seen in cholangiocarcinoma, maybe around 15 to 20%. And in some of the other tumors, like I mentioned, pancreas and gastric, it will be rare. And in this particular case, we had the original tumor also, the one in the pancreas, and that did not show loss of BAP. So it further confirmed that this was actually not a metastatic, undifferentiated neuroendocrine tumor, but a new primary, which was an intrahepatic cholangiocarcinoma. Okay, let me end with this case, which nicely demonstrates how the integration of morphologic, immunohistochemical, and genomic findings can help to make a more accurate diagnosis in certain settings and even define novel entities. So this is a young woman who had a large mass in the liver, and there were no other mass lesions seen on imaging, and no history of chronic liver disease. So here's a biopsy from this lesion. You can see here of sheets of these uniform-looking tumor cells have a trabecular-like arrangement in some places, very minimal cytologic atypia. Mitotic activity was low, and there was no necrosis. In one small area, it showed somewhat like a tubular-like morphology. There were no well-formed discrete glands or mucin, but it did have a sort of a tubular-like morphology in one small focus. So here's the summary of the morphology. Monotonous cell here, you can see the trabecular pattern, which along with the monotonous appearance, sheaths and nests and trabeculae, they all raise the possibility of both HCC and neuroendocrine tumor. CK7 and CK19 both were strongly positive. It was patchy, but strong positive. So these were the two leading possibilities that were considered based on the morphology. Here's the synaptophysin. You can see that there is moderate patchy staining in the tumor cells. Chromogranin, this was a cell block which was also made. We can see patchy staining of chromogranin in the tumor cells. And both these findings, along with the morphology, pointed towards that this could be a neuroendocrine tumor, but it was a more than 20 centimeter tumor without any other known primary. Here's the albumin in situ hybridization. Diffuse and strong positive in the tumor. As I mentioned before, that this very strongly favors that this is a hepatic primary. It could be HCC or cholangiocarcinoma, but this would be a very unusual finding for a neuroendocrine tumor to show such strong albumin staining. So here is the summary of some of the other workup that was done. So all the hepatocellular markers that were not. In terms of neuroendocrine, the INSM1 was done, which turned out to be negative, which also argued against neuroendocrine tumor, along with the fact that it was a large solitary liver mass. Some of the other tumors that can have somewhat polygonal cell morphology were also considered: adrenocortical, renal, mesothelioma, and all of them did not pan out based on the immunohistochemical workup. A variety of other markers were tried for other tumors, and they were all negative. And you can also consider doing mesenchymal tumor markers, but the keratins were pretty strongly positive, and it really did point towards a tumor of mesenchymal origin. Now, based on our experience with similar tumors in the past, an inhibin stain was obtained. And you can see that inhibin is positive. It's patchy, but clearly positive in the tumor cells. And inhibin positive cholangiocarcinomas have been described now. They are still relatively rare, and maybe as we recognize them, we'll find more and more of these cases. There are reports in the literature of a thyroid-like cholangiocarcinomas, And there was a series of 3 cases which was described as cholangioblastic cholangiocarcinoma. And those were inhibin positive. And we recently published a series of 6 cases and referred to them as a solid tubular cystic variant of cholangiocarcinomas, and they are inhibin positive. Now, these tumors have a very wide spectrum of morphologic findings, but they're very, very characteristic. So here is the low part view of one of these tumors. And what you can see here is this tubular growth pattern in this area, very crowded tubules. Some of them are dilated and have this pale eosinophilic material, almost looks like colloid. And that's why the term thyroid-like cholangiocarcinoma was used in the past. And then it can form macrocystic patterns as well. So closely packed tubules, small cysts, larger cysts, all of these are within the spectrum of this tumor. And here's another closer view of the tubular area, showing you how closely it can resemble thyroid follicles. It even has kind of a scalloped appearance like you see in colloid. It has also been likened to granulosa cell tumors, col-axonal bodies of granulosa cell tumors. But when I discussed this with some of my GYN pathology colleagues, they said, no, it doesn't look like that. It's inhibin positive, which also may invoke the possibility that it could be a sex-cord stromal tumor, and this was a young woman. But all the other markers like FOXL2 and others were all negative. They have been negative in all the other described cases as well. Now, in addition to this tubular and cystic morphology, you can get these solid areas. You can see this example here. It's a very sharp transition in this case from this tubular morphology to this morphology of tubercular or solid nested appearance, which can mimic either a neuroendocrine tumor or HCC. So these inhibin positive cholangiocarcinomas are important to recognize because they have the potential to recur and metastasize. Among the small number of reported cases, I think there are 10 or 11 right now, nearly half of them recurred or metastasized. So they are aggressive tumors, just like cholangiocarcinomas. And they lack the typical genomic changes of HCC or cholangiocarcinoma. The very morphology suggests that this has to be a translocation-driven tumor. When you have such a distinctive morphology, and the genomic profile, if you see, they have very low copy number alterations compared to cholangiocarcinomas, which tend to have much higher numbers. So everything suggests that this has to be a tumor which is driven by a translocation. And that turned out to be true. And there was this recent report which described this gene fusion in all these 3 cases of inhibin positive cholangiocarcinomas. And we did RNA sequencing in 4 of our cases, and that's not been published yet, but we found the same fusion in all the 4 cases. The diagnosis in this case, which I showed you, it didn't have the very prominent tubular morphology on biopsy. But it was a 20-centimeter tumor. You can always have errors in sampling. It predominantly showed a more solid pattern, which led to thoughts about HCC and neuroendocrine tumor. And very characteristically, these tumors will have staining for patchy staining with neuroendocrine markers. So the clues to the diagnosis are young women, although it has been described in older women and men as well in a few cases, but a vast majority, more than half of them, did occur in young women. They were all, nearly all the cases, they were large tumors. Inhibin was positive, and albumin is positive, which really helps in confirming that you're not dealing with a metastasis. And patchy synaptophysin chromogranin is seen, not in all, but almost all cases. So anything that looks like a neuroendocrine tumor, large primary in the liver, you should think of this entity. And inhibin stain can help in pointing towards the correct diagnosis in this case. In fact, I was visiting PGI a couple of years back, and there was this case which was being worked up, and I saw it, and we did the inhibin stain, and it did turn out to be positive in that case. And I also remember another case a few years back from PGI where it was diagnosed as primary neuroendocrine tumor. I remember reviewing the case with the faculty there because there was nothing else to offer. Everything else was negative. It was skeleton positive, and the neuroendocrine markers were positive. And I remember now that they were patchy positive. So it's possible that there are more intrahepatic cholangiocarcinomas. In the TCGA database, if you just look at the pictures, there are, I think, 1 or 2 cases which just look like this, and they have this abnormality. It was just not focused upon. So otherwise, it could have been picked up 6 or 7 years ago when that study was done by the NIH. So in a summary, I just want to re-emphasize that there is the overlap of genomic findings in different tumors, and this has to be interpreted in context of the overall case along with the morphology as well as the clinical features. But in selected situations of, in the liver, HCC versus intrahepatic cholangiocarcinoma, in some cases, benign versus malignant biliary proliferations or primary versus metastatic, genomic analysis can really be an important tool along with morphology and immunohistochemistry to make the diagnosis. And in addition to a lot of contribution to the literature, Dr. Das has also done genomic analysis in his studies. And I remember one of his presentations at the USCAP meeting a few years back, where he presented this excellent series of cases, which generated a lot of interest because these pediatric cholestatic cases had a lot of unique genetic findings which had not been described earlier. So I would like to end by thanking Dr. Das. I remember a CME event that he had done many years back along with Dr. Lutra. It was focused only on non-neoplastic liver diseases, and I think that was one of the best conferences I have attended. And I've told Dr. Das many times that I'm still waiting for part 2 of that CME event, which would focus on neoplastic liver pathology. Dr. Das has been my teacher right from my days when I was a resident, and I remember all the some of the qualities he has inculcated, and he's always exhorted us to not just learn about entities, the diagnosis, differential diagnosis, but to go kind of behind the scenes, ask questions about how and why, and that has really stayed with me. Some of the lessons I still remember from my first rotation in histopathology, and then they have still stayed with me. A lot of you have, very eloquently chronicled Dr. Das in the WhatsApp group PGI, and along the same lines, I would just like to end with words of gratitude to Das and Dr. Das, and with a small limerick as a poetic tribute to him. So an high school PGI guy called Ashim Das, a heart of gold, an expert reviewer of class. Among liver sinusoids he strolled, by inspired residents he was extolled. Vows of gratitude to a pathologist, and not only a pathologist, but a person of the highest class. So thank you, Dr. Das, very much, and I'm quite confident that the retirement is just a word, and your passion for liver pathology continue, and we will keep seeing you at liver events like we have been. Thank you once again.
Wonderful, wonderful. Sanjay, thank you so much for a wonderful lecture on genomic analysis of liver tumors, and at the end, explaining people what Dr. Das is about through your appointment. Beautiful. So I think, would you like to take a few questions? There are 1 or 2 questions there. So
yeah, sure.
I'll read it for you. One of our ex-residents, Dr. Munita Balk, who is in Tata Memorial Hospital, Bombay these days, and she used to call me Pitaji when she was a resident, because I think I was guiding her thesis. So she has asked, can fibrolamellar carcinoma arise in a background of cirrhosis? That is one question.
So there have been some reports, they're quite rare, of either fibrolamellar, and in some of the reports they were called fibrolamellar-like carcinomas in the background of cirrhosis. And so they were all in the older literature. I personally have not seen a fibrolamellar in cirrhosis, and among the colleagues that I've talked about, especially one of my colleagues in Mayo Clinic, Dr. Torbinson, he has done a lot of work on fibrolamellar. From what I know, he's also said the same thing, that he's not seen. But I think it can occur. Theoretically, it can occur. So it doesn't exclude the diagnosis. And now we have the tools to make the diagnosis. So if there is a tumor, let's say, which looks like fibrolamellar, and it is in a cirrhotic liver, now we have the tools. If it shows the same fusion that we talked about, then we can show it's not just based on subjective interpretation, it's a more objective interpretation. But so far, as I know, it has not been convincingly reported in the background.
Okay, so there is a question from one of our DM students, DM histopathology students, who says that who wants to ask what are the differences, morphological and IHC differences between a serous HCC versus cholangiocarcinoma? I think you might have already touched at this point.
Yeah, so the important differences that I've mentioned 2 or 3 important points. So serous HCC resembles cholangiocarcinoma because of the fibrous stroma, and that is why even the imaging diagnosis of serous HCC can be difficult, because on imaging it can mimic findings of cholangiocarcinoma. Morphologically, most of the serous carcinomas, morphologically they look like HCC. They have a haploid morphology, but they just have abundant fibrous stroma. Immunohistochemically, they can overlap with cholangiocarcinoma because the numbers of CK7 and CK19 positive cases is very high. So 60 to 70% of them will be positive for CK7 and CK19. And around 20 to 30%, only 20 to 30% will be HAPR positive. So that's one of the pitfalls in diagnosis. So arginase and glypican-3 have a much higher sensitivity in serous HCC compared to HAPR. But the numbers can vary. So in our series, it was 30 to 40%, but it may be a little higher in some others. But in general, HAPR has lower sensitivity in serous HCC.
So, okay, thank you. And there is a question from Dr. Mukul Vij. He's asking, how is HNF18 for cholangiocarcinoma? What is your experience? HN1B, sorry, from the distance. So, Dr. Sanjay, we are doing it here, but results are not very consistent.
Yeah, I would totally agree with that. So our GYN colleagues have been using this for diagnosis of variants of endometrial carcinoma. So I didn't even realize that we had the antibody till a couple of years back. And so I started using it. There have been reports that it can be useful in cholangiocarcinoma. I know Dhanpat had mentioned that. And I have been using it now for maybe last year or so. I've seen overlaps, and the overlap is significant. So I have started doubting its utility. So when I did in the first 10 cases or so, it looked like it's going to work great. But in the last few months, I've seen many HCC cases that are positive. So I'm not really sure right now whether it can be really helpful.
Okay, thank you. There is a question from Dr. Malini. She is online if she wants to ask herself. Otherwise, probably I will have to ask on her behalf. Malini, are you there? Okay. And she had asked that can you have a small duct and large duct type of SCC morphology in the same tumor? That was the question. And is it common to see these tumors in perihilar areas?
So the intrahepatic cholangiocarcinoma, small duct, large duct type. So the perihilar is typically large duct, and the periphery is more small duct. And I've not been a very big fan of this classification because I think there is overlap, and there is no lines to be drawn what is small and when it becomes large. And there are cases, like the question included, there are cases where you can have both small and large duct. So right now, this classification is largely academic because it doesn't really have any direct clinical implications.
Okay, Sanjay, there is one more question, rather two. So Dr. Dilip Ramrakhiani is from Jaipur, and he's a pathologist, and he's asking, can we use IDH and P53 IHC as surrogate markers for molecular analysis to prove a tumor as cholangiocarcinoma?
P53 is a mutation which can occur in a wide variety of carcinomas, including cholangiocarcinoma and HCC. So it will not distinguish or will not establish the diagnosis of cholangiocarcinoma itself. IDH immunohistochemistry is not useful typically because the antibody that's available, the mutation or the specific mutation, at least the one that is widely available, that is the one which occurs in gliomas. And that specific mutation occurs only in a minority of cholangiocarcinoma. And the mutation that occurs in cholangiocarcinoma, at least I don't know of any antibody that's commercially available for those. So for that reason, immunohistochemistry is not that helpful. Plus, if you do immunohistochemistry, even if, let's say, there was an antibody available for that specific mutation, then it would pick up only the subset of cases which have that specific. Because IDH one can have, there are some which are more common, but if you don't do the sequencing, then you will miss some of the others. Plus, sequencing also helps in picking up other mutations, like it can help in FGFR2 fusions or BAT1, because IDH is only in like 10 to 20%, or depending on the series, some have 30% of cholangiocarcinoma. So if you do the sequencing, then you get the whole profile, including the other mutations.
Okay, thank you. There is a question from Dr. Uma Nahar. If she is online, she can ask herself, or I would have to ask
Ajay has a query.
Ajay, I'll come to Ajay. Uma Nahar wants to know, I wish to know about inhibin positivity. When do you decide to do, and what morphological patterns are there?
Yeah, so the case I showed you, when we see this kind of a solid nested pattern mixed in with a tubulocystic pattern, that would be the most characteristic morphology of the tumor that I showed. I'm still not sure whether inhibin positivity makes the diagnosis, because inhibin is just a immunohistochemical stain. So we may still have not encountered cases of the same tumor which are inhibin negative. So I think inhibin positivity helps in the sense that if you are thinking about this entity, then it will point you in that direction, that and you can exclude other entities, then it can help to make the diagnosis. So any tumor, especially the setting that I explained, large tumor, primary tumor in the liver, especially if it's a younger woman, even if it's not, which you cannot clearly diagnose HCC cholangiocarcinoma, you are getting this patchy staining with neuroendocrine markers. In all those settings where the answer may not be clear, you can try inhibin and see if that is positive. But I think with this fusion that has been described, as we get to know more and more on larger number of cases, that may be necessary to make the diagnosis. Or if larger number of cases show that inhibin is almost always positive, then that may also help to just confirm the diagnosis without the demonstrating the genetic change.
Okay, I think Dr. Ajay Duseja wants to ask.
Yeah, Sanjay, I think nice talk as always. Just two questions on HCC. One is we discussed during the talk about the utility of doing FNAC or FNAB in HCC. As I said, I think there would be a small group where the radiology is kind of inconclusive, or clinically we are not able to distinguish, and there we will like to do the either FNAC or FNAB. And you yourself said that the molecular typing is really not of much help. And the differentiation of the tumor, I think we can know these days, by whether these tumors are AFP secretors or non-secretors, or even by, FDG PET. So FDG PET also tells us whether it's poorly differentiated or well differentiated. And so that helps us in prognosis. And as far as the treatment is concerned, unlike, CA lung, where, looking at the EGFR mutations would be very important to look at the response for tyrosine kinase inhibitors, that's not the case in HCC. So the point I'm trying to make is that I think there's no real strong ground where, histology or morphology can help us in managing these patients clinically, but for, a very, I would say, a minor kind of, percentage. But having said that, I think after my last discussion with you, we have started an intramural, work here where we're looking at the, FNAC and FNABs in these patients. But your thoughts on this, that what would be the role of tissue diagnosis in HCC, number one. My second question is about the non-cirrhotic HCC. That was the first question was about the cirrhotic. This non-cirrhotic HCC, especially in NASH, is really coming up in a big way, and we are seeing more and more of NASH related HCC which are happening in a non-cirrhotic setting. And usually because they are not under the surveillance program, when they by the time they come in, these tumors are usually very large and advanced, and we really can't offer them either a transplant or resection, and they are left with only non-curative modalities like loco-regional treatment. So my question to you is that in the non-cirrhotic HCC, morphologically, does anything help you? Or now people are also talking about the techniques like the cell-free DNA or the liquid biopsy or the copy number variants. So liquid biopsy role in a non-cirrhotic kind of, say, NASH related, or for that matter, any etiology, which can help us in early diagnosis in a non-cirrhotic HCC. So 2 questions for you. Thank you.
Yeah, thanks, Ajay. Yeah, both challenging questions. So the first one regarding the role of morphology in HCC. So we all know that the ASLD and the EASL and other liver societies also have long have radiologic criteria for diagnosis along with AFP, and now we have this LIRADS scoring for liver lesions. So LIRADS 4 and 5 are typically not biopsied. So I'll just tell you my own experience right now. So that's how our hepatologists are also practicing. So our oncologists are more keen to do biopsies, but our hepatologists are less keen, and the transplant hepatologists do a lot of management based on radiology. But now we have a database, it's not very big right now, where LIRADS 4, 5 cases were biopsied. And I can give you some anecdotal examples. There were 2 cases, I think one was 4, one was 5. And they were, I don't know why they were biopsied. That we have to sit down with radiology and discuss why did they biopsy. But these lesions both turned out to be FNH. They were not malignant.
HCC.
And there have been other instances of LIRADS 5 cases, a few of them, which turned out to be cholangiocarcinoma. So there is a small number of cases, and I think because we don't know the denominator, it's very difficult to say the percentage, because since they're not being biopsied, we don't have a reliable denominator to give you a percentage on how much these cases would be. In hepatology, 4 or 5 years back, the journal Hepatology, there were 2 editorials written, one by 2 pathologists, and then the others were written by 2 hepatologists. So it was a very nice debate. Both the pathologists strongly advocating that liver biopsies should be done, and both the hepatologists advocating that no, it's not necessary. So I think that debate is still kind of continuing. The 2 advantages that I would see from a biopsy is, number one, in at least most cases, you can confirm the diagnosis. And as I mentioned, there are instances when the radiologic diagnosis and pathologic diagnosis, there's a discrepancy. Second, with the availability of targeted therapies, now we have, I think the SGFR2 fusion, the drug was approved. And from what I hear, IDH1 is either approved or going to be approved also for cholangiocarcinoma. So the importance of making those diagnoses with the genomic profiling, especially for unresectable cases, has gone up even more. So that's why our oncologists are very keen to do the biopsies. So that is where we are right now, that there is this difference in approach among our different clinical teams on what would be the exact role of liver biopsy. But like the example you gave in lung, that has been argued that is the reason why we don't have good targeted therapies in the liver, because there is no tissue. In the lung, they have been, they've in nice classification based on genetics, and all the treatment is based on that now. And in HCC, one of the arguments has been that all the trials that have been done, or most of the trials, apart from the recent immunotherapy ones that have been done, were negative because all the HCCs were lumped together. And HCC is not one tumor. It's based on its profile. You can classify it into many subcategories. And if you lump it together, then that's maybe one of the reasons that a lot of the trials have been negative. And regarding the second question about the, the non-cirrhotic HCC, the non-cirrhotic liver, and we see that actually quite often. I would say because the biopsies are being done more often. That's why we see it more often in pathology. And typically it's been said it's 10 to 20%, but in our practice tends to be higher because they're being biopsied more. And our oncologists really are doing what you mentioned, the circulating tumor, the liquid biopsy. And we have a few cases in which the changes that were seen corresponded to the exactly the same mutations were found actually in the tissue biopsy also in sequence. So I think that's an area that is evolving. It's not fully established how to use the liquid biopsy in management, but our oncologist, one of our oncologists, is very keen and has been doing it on almost like a routine basis.
Thank you.
Okay. There is a question from Dr. Madhumita, and she is asking, FDG avidity and histological grade of HCC are not correlating always. So your thoughts?
Yeah, and I'm not aware of how FDG. I mean, Ajay just mentioned that can be useful. So I think the comment is that it may not always be. I think histologic grade of HCC is very challenging. Sometimes pathologists are also not correlating with each other also on what the grade might be. And part of the reason is that the definitions of the grade are very broad. That makes it somewhat subjective. But I think on biopsy, most can agree whether it's poorly differentiated or not. Well and moderate, there can be sometimes inter-observer variation, but most people can agree that this is poorly differentiated. And some centers like University of Toronto have used differentiation as a criterion for transplantation. So they exclude patients who are poorly differentiated and they don't transplant them, especially if they are outside the Milan criteria. While HCC outside the Milan criteria, if they are not poorly differentiated, they will go ahead. There are varying practices across different transplant centers.
Yeah, so pathologists not agreeing is a positive sign, I think. So it should be taken positively. Okay, so I think, can I ask other people in the panels to say or comment anything? Yes, Dr. Dhanapati is there, so please go ahead.
No, I just wanted to thank you for organizing this event. And I'm glad that I found out about this just yesterday, but I'm so happy that I did. And I just wanted to say that, what a privilege it has been to learn from Dr. Ashim Das and be so at the same time that he was there at PGI. He has been characterized in so many different ways that really truly tell who he is. I think Sanjay is a master of using words and poetry and other things to describe people, and he described Ashim very aptly. I would just say that you have been such an inspiration for so many people and such a great teacher that I'm sure that you will be missed in PGI and everywhere else. But I'm pretty sure that you will continue spreading your wisdom and knowledge even after retirement. Retirement is just a kind of landmark in our lives, but it's not the end of anything. And I think the life beyond retirement exists and probably better than what it's before. And I'm pretty sure that Siddharth can probably, say more about life beyond retirement. I'd just like to say that, thank you for all the years of your service to not only PGI, but to everybody else. And, for many of us who are now liver pathologists, like you, we never started our career as liver pathologists. Most of us will remember that when we were doing pathology, we did everything. And when we were in PGI, we never ever thought that we will become liver pathologists. But for us, you have been a role model pathologist. You have done everything. You did dermatopathology, you did neuropathology, you did everything else that was possible, except for not going to territory of your wife, Dr. Adhika, which is you left alone, and wisely so. Uh, and one of the other characteristics that we always remember you is that in a place which is very complex and stressful and a lot of things happen every time, you always maintained a very calm demeanor and never get angry. So it is one of those rare things where if you ever see Dr. Ashindas angry, something must have really happened. I mean, otherwise you're always unrattled, always calm, always in control. So thank you very much for all the years of guidance and being there for us as a role model. Thank you.
Thank you, Dhanapad. And I would say on behalf of the Department of Histopathology that we are grateful to you that you joined. You made the discussions very fruitful. And despite early morning there in US, you have been able to join us. We are very grateful to you. Thank you so much. Datta Gupta wants to say something.
Yeah, first of all, Dr. Sanjay Kakkar, another brilliant talk. And I think I've been doubly enriched, because in the June issue of Indian Journal of Pathology and Microbiology, Dr. Dhanpat Jain has written an excellent review on the different morphological patterns of HCC. Dhanpat, that was also a wonderful article. You and I think Monica Vyas, both of you joined together, just published. Yeah, I want to tell you one thing that I think we have not only opened our eyes. If I recall the number of times we must have missed or misdiagnosed cases are, I mean, it's just flashing in front of me. I think Dr. Duseja, what he says is exactly right. See, brain tumors now, you have to do these different molecular analysis. Others, they won't touch it with a barge pole also to start any treatment, just like the lymph nodes. And in the liver, it's all because of the previous, there were few reports, there were a lot of needle track injuries and needle track seedlings. And especially when they did this radio frequency ablation also, with those J kind of things, and all of them showed needle track, and so people were loath to doing biopsies or even FNACs. And as Dr. Kakkar says that slowly we started getting less and less tissues of HCC, triple phase CT, alpha fetoprotein raised to make it HCC and so on. So I guess now these things will help. Sanjay, I wanted to tell you that here, when I've seen cases which are poorly differentiated, you can't differentiate between HCC and cholangio by those triple phase CT or alpha fetoprotein or whatever limited immunos we do. What they do is, if it is resectable, then you treat it like a cholangio. You resect the tumor, remove the lymph node. If it is not resectable, people have tried injecting alcohol and those other things into the tumor. But they wouldn't give chemotherapy, obviously, because you have rightly pointed out in your very first slide that the two chemotherapeutic regimens are absolutely different. So the oncologists wouldn't, unless you give them a proper diagnosis, they wouldn't give the chemotherapy. So that's one thing. The second thing, has anybody tried inhibin in the garden variety of cholangiocarcinomas?
So in the earlier report that was published, they did 10, 15 cases, and I've done it in around 25 cases, and I've not seen it convincingly positive. There was one case which showed some focal staining, but I've not seen it so far, but very limited number of cases. I think larger number need to be done.
The second thing is, I do not know, you have access to more cases. Can you see in those intermediate types of cells, is there grooving? Because even in the case that you showed just before that was the last case, just before you started your second part of your talk. In that also, I mean, it was a fleeting thing. I thought that some of them did have. So you could see in your cases, I'm sure you see a lot of them, just in case there are, because some found and I thought that this one.
I've not focused on that, but it's possible that it's present. But
Some
yeah, I
of
mean,
them,
I'm still not sure what intermediate is. Although it's
yeah,
part of the dimensional
that's true.
classification, I think
But
it's just
it's a
not very
part of the
clearly defined.
part of the classification. So we all tend to this one. So
Okay, so I think,
wonderful.
sorry, somebody wants to say something. Otherwise, I was going to say that Dr. Preeti used to be our resident at PGI, and she was guided by Dr. Ashim Das. I sent her a request if you could come and join us, and I think it is very late in Australia, so I thought I would first ask Preeti, how are you? Good evening.
Good evening, sir. It's such an honor to be present here, to be invited by you personally to come on in this panel of August seniors. I'm just starstruck. I'm just rattling out words, I think. But it's an honor and a pleasure to even be in such a passing cloud in PGI that's touched me in ways that I can never describe, and definitely not more elegantly than people who have already done. It's a blessing that I was there to be educated by you too. I mean, I'm not going to say anything from my perspective, but I have a question for all of the senior people there. As Dr. Kakkar had said, the liver biopsies from neoplastic liver lesions is probably traveling towards theranostic aspect, and it's probably going to increase or stay. I want to just ask about what the experts think the future of non-neoplastic liver pathology is going to be. Say, I've finished my residency in PGI in 2013, and I've been dabbling in and out of liver pathology and still a center in my set of interests that I really want to do liver pathology and especially non-neoplastic liver pathology. How it's going to evolve, what's going to be our role in the future, and what's going to happen? Like, what would you say to a young aspiring I'm not sure whether I can say young, but an aspiring liver pathologist like me?
I think you have to ask Dr. Ajay or Dr. Barinder Singh, because they have to provide us this. So those two are there, so they can talk.
Dr. Virendra Singh is saying something.
Yeah, we hardly get a biopsy now in patients with Hep B or Hep C or HCC, and only condition where we ask for the biopsy is the autoimmune hepatitis. And even in alcoholic hepatitis, we basically base the diagnosis on the clinical grounds only. So I find that the slowly the role of biopsy is going away, especially in the uh, the liver biopsy.
Okay.
If I may say something, and regarding this issue, I think this is something which I think everybody faces throughout the world. The changing incidence as well as changing pattern of liver biopsy. And I think the role of liver biopsy is going to evolve. Over the years, it has evolved. It will continue to evolve. The indications will change, and as more knowledge evolves and more other parallel technologies evolve, it will continue to change. The thing is that it's also dependent on where you practice and what are the local socioeconomic issues as well as disease patterns. Socioeconomic factors are very important because liver biopsy is expensive, it is invasive, and there are many other things associated with that. So if you can get not perfect, but very good, almost perfect results by other means, people will certainly do that. If I was a patient, I will also opt for those things. But on the same hand, I think Other technologies are also evolving, which I think some of them have not really come into practice, which will guide as to what the liver tissues or any other tissues can be used for. So I would say that one would have expected that the liver biopsy proportion would have gone down everywhere, which has not been the case. For us, being in a developed country where you have more resources, the biopsies are still being performed. The numbers have really not gone down. The diagnosis, the indications have changed over the time. We get more cases of unknown or cryptogenic liver disorders now than hepatitis C and B. We get biopsies, DILI and alcoholic liver disease more than others. And in our setting also, the biopsies of tumors are also done more often than other places, largely because we get unusual cases. There are more resources to do molecular and other things that could be helpful. And also we pick up cases where there's a severe discrepancy between what the clinical diagnosis was and what pathology showed. So it perpetuates the idea that liver biopsy still has a role. But having said all those things, I'm pretty sure that with time, like anything else, it will be more of an evolution of the liver biopsy. And as parallel technologies evolve, you will find different roles and different ways of providing more information. And eventually, I think not only liver biopsy, for every tissue diagnosis, as more non-invasive things are being developed, where you can do in vivo microscopy and things like that, who wants to have a tissue taken out from their body? Not me. So I think we will all move towards those things. Maybe 10 years, maybe 20 years. I don't know.
Thank you so much. Thanks. Dr. Siddharth, you want to say something?
You have to unmute.
Siddharth, you unmute yourself.
Yeah, Preeti, I would like to echo what Dr. Dhanpat Jain said. The indications are changing. It's true for chronic hepatitis, it's almost not required now. Acute hepatitis, it had gone long time back. And for even transplant, earlier there were protocol biopsies. Day 0, 5 or 7, 15, that's all gone. So now the indications are less for non-neoplastic diseases. I mean, different. The number of biopsies have reduced, but actually each biopsy that comes is requires to spend much more time. It's in those diseases where nobody can make head or tail of it. It makes you think much more, makes you discuss a lot more, and so it's become difficult in those non-neoplastic. And the second thing that he said is right, that you'll require a lot of ancillary tests now gradually. Can you imagine in PFIC and all, earlier there was nothing to be done. Now so many tests are being done, genetic tests. So for the metabolic and other diseases, the indications are increasing, what earlier people wouldn't do. And for tumors, of course, sky is the limit now. So don't worry, it's not all that bad. They are not going to banish the needle so soon, although everybody is trying their best, So, and we have done so many theses, whether the NMR spectroscopy is better than biopsy, everything have been a guide to ensure that the biopsy is not done in future. But you see, gradually you'll find that the indications are different.
So
Dr. Dhanpat Jain put it exactly how it will be.
Thank you. I think for Preeti, actually, it is beyond midnight. It must be 1 p.m. there. So I was wondering whether she's still awake or not, but she's, I think, wide awake. Thank you, Preeti, for showing your interest in PGI affairs. So we were very nice looking, nice meeting you on this online and virtually. So thank you very much for joining. And
thanks very much, sir. It's my pleasure and honor.
So okay, so I think we are nearing 8 p.m. now. I think so we have to wind up also. Before I say thank you to others, I think there is one of the students of Dr. Das, and I had asked her if she could also join. She has been listening and she asked some questions also. It is Dr. Sunana Mishra, and from Delhi. She is, I think, in GV Pant these days, faculty. So she wanted to say something for Dr. Das, and I thought that was very sweet of him. So I think we will listen to her first, and then I will propose word of thanks. So Nana, you are there, then please switch on. Very good.
Yeah.
Thank you, sir. Thank you so much for giving me this opportunity. I am presently at RML Hospital. I had written a small poem for Dr. Das, and BDR Radotra sir was kind enough to make me read it out to you, all of you, and I'm so grateful to sir for that. So I'll just take 2 minutes. This is for a slam book that I had written. As the rays of the sun strike the window, you walk into the reporting room steady and slow. A twinkle in your eyes, a slight curve at the lips. Waiting are the stunted duodenal villi and inflamed colonic crypts. Peering down the microscope, we hear you say, "Who's the poor chap? Abhi ye kya hai?" Seems to be an epidemic of squamous cell carcinoma. You smile as you put on the very next slide, for it is a case of the beloved non-Hodgkin's lymphoma. The slides speak to you, the cells do a little jive. Now, was that an LVI that missed our eyes? The liver surely holds a special place in your heart as you dissect out the biliary tree like a prized piece of art. CPCs with you seem not such a daunting task. Each and every mystery, the final autopsy diagnosis you unmask. With such flair and finesse, you stitch up the tale to the bottom of the very minutest detail. Every day, every week, every month, every year, you teach with the same conviction and rigor. Each time there is a new batch of residents, and you make pathology fun for all your students. I imagine you, sir, with your microscope and a room full of slides, with a view, perhaps a cup of coffee by your side. Thank you. Thank you, sir, for
Thank you,
everything.
Sana. Very well.
Thank you.
Thank you. And we appreciate your gestures. And you want to say something?
No, I'm really,
Before I say propose a vote of thanks.
I think this is a remarkable event. Hearing from so many people, I never thought I'm really worthy of that or not. But whatever it is, really, I'm really thankful to all of you, Bishan, and lot of people, those who are really giving these appreciations for me. And I really, I'm really thankful to all of you. Thank you, sir.
Thank you so much. And I think for my colleagues in the department, they are going to have 2 more get-togethers on the 31st. So they will have enough time to express their feelings and gratitude. Dr. Radhika, you are still there, and if you wish to say now something, please. Otherwise, I think I'll definitely ask you on the 31st.
No. I only want to say a big thank you to you, Dr. Bishan. You have taken the lead. You have organized this session, and I think, I am really emotional at this point of time. So I can't really speak much, but I can only, from the bottom of my heart, say a big thank you to you and the entire department and all the students and everyone who's been there. Thank you so much. It means so much to both of us.
Yeah, thank you. No, you're welcome. In fact, these are the moments when one becomes emotional also. When I was handing over a bouquet after the CPC, I became a little emotional. And my voice changed that time because we suddenly realized that this is his last CPC and we won't see him perform a CPC again. So these are the things. But anyway, we thought that we would make it a brief event from 4 to 7 so that Saturday people don't have time. It's a long weekend in India also. Monday is a holiday, so I had thought that we cannot go for a long session. So which in fact again turned out to be 4-hour session. So on my part, I would like to thank the 3 speakers. Dr. Ashim, and I'm sure he will be around, and I'm going to catch hold of him for many things. Ashim, I would thank Dr. Datta Gupta and Sanjay for their brilliant talks, and I'm so happy that the discussions were quite a lot, and this discussion was generated because of the gracious presence of Dr. Dhanpal Jain. We are very grateful to you for chipping in, and despite early morning there, and despite knowing so late that in fact we were also very hesitant whether to do it or not. I am very thankful to my clinical colleagues, Professor Brinder Singh. Still on a Saturday evening, he is still listening to us. Thanks for your time. And I think Madhumita has been very active there. Ajay, very, very grateful for participating and for lending us support. I am very grateful to other pathologists from India who had joined us. Very grateful to Dr. Bush, who could also make some comments. I am really grateful to my colleagues, and I can tell you they are very fond of Dr. Das, and many of them are really going to miss him. I asked them to come over here and be with me, but I think because of the COVID protocol, it's a small room, so we cannot be assembled here. So I thank them for making this effort. I have two colleagues here, younger ones, Dr. Devajyoti Chatterjee and Subrodeep, just to lend some logistics support. So I am grateful to them. I would also like to mention that Pulkit used to be with us in histopathology. He has been a great fan of Dr. Das. So now he has shifted to hematology. But I am grateful to him also for all these things. So I really thank to each and every one of you to make this CME a successful thing. And thank you so much. We would probably log off now. Sanjay, thank you very much. Siddharth, Dhanpat.
Thank you.
Specifically, thank you so much.
Thank you, sir. Thank you. Thank you.
And, Ajay, I'm very grateful.
Thank you. Thank you.
Sanjay.
Good night.
Thank you. Bye-bye. Good night.
So before we part, do we want to have a screenshot?
Pardon?
Yes,
Sure.
screenshot.
Everyone, please.
We have a screenshot for all the those who have logged in.
Yeah, please. Thank you
So
for
everybody's-
reminding us. Oh, see,
Everybody
please also
please,
there.
switch on your
Yeah,
video.
no,
All
good.
those who are there.
Oh, very good. I couldn't see your faces. Now I'm happy.
We couldn't have left even a second.
Thank you for reminding.
Please, all those who are online, please join.
It is not there.
Switch on your
Kitty
videos, please. Kirti,
and
I can see Geeta, Gitanjali.
Tanjali, if you are there, please switch on your video.
Preeti can join.
It is there.
Sanjay is there. Sunaina and Dr. Singh is there.
Yeah, Gitanjali is there. Very good.
Oh.
Geeta, nice to see you. Good.
Ritambara is not there now.
Ritambara will come.
Switch on your camera.